Hello.
Sir, please start.
Am I audible? Clear?
Yes, sir.
Hello, everyone. Let's start our discussion on NEET super specialty questions. Actually, the problem with this exam is you cannot guess the weightage of the each specialty. So you have to give equal importance to all the specialties. In last year NEET super specialty exam, there are around 10 to 12 questions from the urology. Previous year it was around 7 questions, but last year it was around 12 questions. So let's start with the first question. The first question, this is a image based question. Okay. Whenever you get an image based question, first you have to identify what kind of image is, what that image is. This is an image of intravenous pyelogram. So the answer here is a bilateral ureterocele. You can see the cystic dilatation of the distal part of the ureter that is present in the bilateral in this case. So the answer is bilateral ureterocele. Why not the other options? Because if there is a bilateral vesicoureteric junction obstruction, there will be a gross dilatation of the upper tracts and there won't be any cystic dilatation. So the first option is ruled out. And if it is a bilateral ureteral cyst, there will be a filling defect rather than a cystic dilatation. So here the answer is bilateral ureterocele. So this is a classic IVP picture where it is showing the adder head or cobra head appearance on intravenous pyelogram. This is a ureterocele. So what happens in a ureterocele is there is a cystic dilatation of the intramural part of the ureter because of atresia of the orifice. Females are more commonly affected, around 4:, compared to the males. The ratio is 4:1. And 10% of cases, there will be a bilateral involvement of both the ureters. That is, ureterocele will be seen bilateral in 10% of cases. And the classic appearance is cobra head sign or cobra head appearance or adder head appearance. Some of the other important questions that can be asked from this topic, these are potential MCQs, like when you will do the postnatal ultrasound, if the prenatal scan has shown the ureterocele, so you have to perform the postnatal ultrasound at 4 to 6 weeks of age, because if you perform the ultrasound before that, there are chances of false negative results. And voiding cystourethrogram, you have to perform at 4 to 6 weeks of age. While performing the before we perform the voiding cystourethrogram, you have to confirm whether there is any UTI or not. In case of UTI, you have to postpone this test for a few more days and you have to treat that UTI first. And CT urogram, it will be useful to delineate the lower tract and upper tract. And MAG3 scan, this is a functional scan. Ideally, this scan is done at the 3 months of age after detection of the ureterocele. Okay. So the treatment of this ureterocele is you can perform a simple surgical excision of the ureterocele and the reimplantation. Reimplantation can be 2 types of approaches. One is extravesical approach, another one is intravesical approach. The extravesical approach, the technique is Lich-Grigor technique, whereas the intravesical, it is a Ledbetter-Politano technique or Cohen's technique. Another important question here is the Paquin's rule. Previously, they used to follow this Paquin's rule. That means the length is to breadth of the, that means particularly the intramural length of the ureter should be 5 times more than the diameter of the ureter. That is the Paquin's rule. This should be followed while you are performing the reimplantation of the ureter. But the recent studies have shown that 3 times the diameter, that is 3:1 ratio, is adequate and enough, because this Paquin's rule is overestimating the length of the intramural ureter. So this is about the Paquin's rule. And next one is for simple ureterocele in infants and small children, you can go with the endoscopic incision. So this is the first question. The next question, this is also an image-based question. This is about the crossed ectopia. Actually, you have to understand the definition of what is ectopia and what is crossed ectopia. In case of ectopia, that means the kidney can lie in the anywhere along the position of as a path of ascent. That means the kidney can be lying at the pelvic region, or it can be at iliac region, abdominal, or rarely sometimes in the thoracic region also. That means the kidney fails to reach the normal location in the lumbar region. That is what the ectopic kidney means. But what about the crossed ectopia? The crossed ectopia means the kidney will be located on one side and the insertion of ureter into the bladder will be located on the opposite side. That is what the definition of crossed ectopia. That means the kidney is located to the contralateral side to the ureteric insertion. What is the problem associated with this renal ectopia? Not about the crossed ectopia. What are the problems that are associated with this renal ectopia? Means these kidneys can be more prone to develop reflux, pelviureteric junction obstruction, and uretrovesical junction obstruction. So, from the last year question, the answer is the crossed renal ectopia without fusion. This is a McDonald and McClellan's classification. This question is taken from the Campbell. So, concentrate on the first picture. Actually, it is a crossed renal ectopia without fusion. Here, the renal ectopic kidney, that is crossed ectopia, means the kidney is fused to the normal kidney is present on one side, and ectopic kidney, which is present on the opposite side, and it is fused to the kidney. Then it is called crossed renal ectopia with fusion. If it is not fused, but the insertion of ureter is present on opposite side, then is crossed renal ectopia without fusion. If there is only single kidney, the kidney is only single kidney and it is located on one side, the insertion into the bladder is present on opposite side. That is called solitary crossed renal ectopia. And last one is bilateral crossed renal ectopia. That means both the kidneys are present in normal location, but the ureters are inserted into the opposite sides in the bladder. This is about the McDonald and McClellan classification. These are the different forms of crossed renal ectopia with fusion. Okay, these are all with fusion only. Suppose this is a normal kidney. So this is normal kidney which is located on the left side, and this is the renal ectopia, that is crossed ectopia. Here the kidney is present, normal kidney is present in the normal location, but if it is fused to the inferior pole of the kidney, this ectopic kidney is fused to the inferior pole and its ureter is located on opposite side in the bladder. Okay, opposite side in the bladder it is located, then it is called inferior ectopia. Suppose if the ectopic kidney is fused to the superior pole, okay, if ectopic kidney is fused to the superior pole and the insertion of ureter is located on opposite side into the bladder, so then it is called superior ectopia. The first and last images are inferior and superior ectopia. Suppose if the kidney is present like this, one side, and opposite kidney, that is whatever the ectopic kidney we are talking about, it is fused to the lower pole in this manner, then it is called sigmoid kidney or S-shaped kidney. You can see the S shape. So this is sigmoid kidney or S-shaped kidney. And if the kidney is lying horizontally like this, so this is a L-shaped kidney. One kidney is fused to the lower pole and it is lying horizontally, then it is called L-shaped kidney. If both the kidneys are fused like this, then it is called a disc kidney. And lastly, if the kidneys are fused in an irregular fashion, then it is called a lump kidney. So these are different types of crossed ectopia with fusion. Okay. And the next image, this is also image-based question. This is based upon the congenital pelviureteric junction obstruction. So in this patient, they have asked about the treatment. How do you manage this case? Okay. So the first option is high anastomosis. No, this is always you have to perform a dependent anastomosis in a case of repair of congenital pelviureteric junction obstruction. You have to excise the redundant pelvis and you have to perform the anastomosis in a dependent way, that is in Anderson-Hein dismembered pyeloplasty. DJ stenting and follow-up, actually this will relieve the obstruction, but after removal of the stent, again the obstruction will develop, that is dilatation will again occur. So this is not a definitive treatment. Observation and repeat scan after 3 months, this is not at all an answer, because observation will lead to the loss of renal function. Because of hydronephrosis, there will be a thinning of the renal parenchyma, so further loss of function will be there. So in this case, you have to operate. The treatment of choice is Anderson-Hein dismembered pyeloplasty. So this congenital pelviureteric junction obstruction, this is the most common cause of unilateral hydronephrosis, which is seen in 1 in 500 live births. So what are the different causes of this congenital pelviureteric junction obstruction? Because it can be because of an intrinsic narrowing of the ureter. See, in the first picture, you can see there is a intrinsic narrowing of the ureter. In second picture, you can see lower pole crossing vessel. Because of compression from this lower pole crossing vessel, there is a dilatation of the pelvis. So these are the different causes. So, and the third picture, if you see, this is a duplex system where the upper pole ureter is normal, but the lower pole ureter has developed the dilatation and congenital pelviureteric junction obstruction. This is intraoperative picture. where you can see my cursor. It is showing the grossly dilated pelvis from the lower calyceal system, that is from the lower pole. So what are the different pathogenesis mechanisms? Why this congenital pelvic junction has developed means it can be because of development of this aperistaltic ligament, and less frequently it can be because of a true stricture also. But in around 63% of the cases, there is a aberrant lower pole vessel which is compressing the ureter, because of which there is a congenital pelvic junction obstruction. But these lower pole vessels will be seen in 20% of normal individuals also, but there won't be any obstruction in those patients. So the other rare conditions are external bands, kinks and valves can also be formed. So what is the surgical treatment of choice in a patient of congenital pelvic junction obstruction means it depends upon the what type of renal pelvis it is, whether it is an extrarenal pelvis or intrarenal pelvis. Suppose if it is an extrarenal pelvis, in those conditions, the best surgery of choice in these patients is Anderson-Hind dismembered pyeloplasty. The important characteristic features of this surgery are it should be a dependent anastomosis, funnel shaped and wide enough to drain adequately, and it should maintain good vascularity, and it should be present without any tension, and you have to excise the redundant pelvis. This picture is taken from Love and Bailey. Second picture, you can see clearly that how do you perform this Anderson-Hind pyeloplasty means you will remove the strictured segment. After that, the ureter will be spatulated. Always the spatulation of the ureter should be done in the lateral side. Okay, this is the spatulation, and after the spatulation, you have to anastomose this in a with the intermittent sutures. Always intermittent sutures should be placed, and degestant should be placed in the position. So why not the rest two options? I have already discussed about this. So what are the different? I have discussed about what is the surgical procedure of choice for the extrarenal pelvis. Okay, there are some other techniques also for the extrarenal pelvis. Extrarenal pelvis congenital pelvic junction obstruction. These are called non-Anderson-Hind techniques, which includes Foley's viviplasty, Culp Dewart spiral flap surgery, Scardino and Prince vertical flap, intubated ureterotomy, and ureterocalicostomy. Except this ureterocalicostomy, the rest of the four options are done for the extrarenal pelvis, whereas the ureterocalicostomy, this is particularly done for the intrarenal pelvis. So the first one is Foley's viviplasty. This Foley's viviplasty is particularly done for the high ureteric insertion. See, if you see the first picture, here you can see the insertion of the ureter is very high on pelvis. So if in this condition, you can develop this V-shaped flap, and you can first you will suture the posterior margin, and then you will suture the anterior margin with the placement of digestant in situ. So the surgical procedure of choice for high ureteral insertion is Foley viviplasty. This is very potential image-based question for NEET super specialty. And if there is very large extrarenal pelvis and long proximal ureteric stricture, then you can perform the spiral flap technique, where you will raise the flap in a spiral way, and you will bring that flap in a door, like a door. See, you will open the flap like a door, and you will suture in the posterior margin first and followed by the anterior margin. So this is for the large extrarenal pelvis with long proximal ureteric stricture. Next is vertical flap technique. That is a box-shaped pelvis. If there is a box-shaped pelvis and the insertion of the ureter is located in the medial margin of the pelvis. See, this is a box-shaped. You can see my cursor, and the ureter is inserted at the medial margin of the pelvis. So in this condition, you can go for this Cardino-Prince vertical flap technique. And this one is intubated ureterotomy. What is this intubated ureterotomy? Here you can see a very large stricture, extremely long stricture is present. Or if in case of a multiple strictures, if multiple strictures are there, then you can perform this intubated ureterotomy. You will, similar to the spiral flap technique, but here you will leave the small portion of the ureterotomy without suturing. It will heal by the ureteric regeneration. So you can see the third picture. See option here, the C picture. In this, you are not able to close this distal part of the ureterotomy incision. You will leave it to heal by the ureteric regeneration, but you will place a digestant for 6 weeks. And after that, the last one is the ureterocalicostomy. Suppose if it is a very small intrarenal pelvis, there you cannot perform this Anderson-Hind pyeloplasty or different types of non-Anderson pyeloplasty techniques, what I have told. But in this condition, you can perform the ureterocalicostomy, where you will excise the small portion of kidney. That means you will do the lower pole partial nephrectomy. Very small amount of kidney will be removed, and you will anastomose the ureter after spatulating on its lateral end to the lower pole of the kidney, lower calyxes of the kidney, and you will assess the function of this kidney after 2 months after the surgery. So these are different types of techniques for the management of extrarenal pelvis and the intrarenal pelvis. So the next question, this is also question based upon the pelvic-ureteric junction obstruction only. In this, the patient is 25-year-old male. He had underwent the open pyeloplasty. This patient presented with flank pain. On imaging, there is a gross HUN and there is a stricture also. Here the catch is the E. coli positive urine culture is there. But here in this question, he is asking about the treatment of choice. What is the next step? He is not asking about the what is next step. He is asking about the treatment of choice. So the conservative management with antibiotics is not the option. Only the option is endopyelotomy. Usually the endopyelotomy is reserved for the cases after like previously the pyeloplasty was done. Now the patient again presented with the stricture. In those conditions, this endopyelotomy is usually done. Okay. Of course, you will place the PCN to tackle with the hydroureteronephrosis, and endoscopic management will be done by performing the endopyelotomy. Okay. When you will perform endopyelotomy, if there is functionally significant obstruction after the pyeloplasty surgery, then you can perform the endopyelotomy. But the contraindications are if there is a long area of obstruction, because endopyelotomy means you will incise the ureter in the lateral part of the ureter. Okay. So if it is a very long stricture, you cannot incise all the way. So only for small areas of stricture is there, then you can relieve with the endopyelotomy. And if there are concomitant upper tax stones, if already the stone is also there, you have to remove the stone also. So endopyelotomy won't be sufficient. You have to remove the stones also to relieve the significant obstruction. So these are the indications and contraindications of this endopyelotomy. How do you perform? This technique is usually performed by, usually you can use a flexible scope or 7 French or 6.9 French semi-rigid URS scope. You will use a holmium laser fiber, which is of 200 micron or micrometer or 365 micrometer. And what is the position of the incision? You have to always incise in the lateral direction only. These are the technical settings, 0.8 to 1.2 joules and at the frequency of 10 to 15 hertz. And what is the extent of surgery? When you should stop giving incision? That means you have to incise the stricture segment all the length, but depth. What is the extent of the depth? You have to go for the incision. When you have to stop means when you see the peripelvic fat, or if you are able to see the periureteral retroperitoneal space. In those conditions, that means you have reached the limit of your surgery. So this is all about the endopyelotomy. So why not redo pyeloplasty or lap pyeloplasty in this patient? Because it will be very difficult to perform a redo surgery in a after open pyeloplasty. So dense adhesions will be there, and it will be difficult to tackle. So usually endopyelotomy is the best and preferred option for the obstruction or stricture after the open pyeloplasty. So the fifth MCQ, this question is based upon the percentage. Actually, the classic triad of flank pain, hematuria, palpable mass will be seen in what percentage of RCC patients. So this is also known as a two-late triad. This exact number is not given in Campbell, but it is seen in less than 10% of cases. This is mentioned in Sabiston as less than 5% of the patients, but in the options, the closest option is less than 10%. So this is also known as a two-late triad. So this is some of the important one-liners that are related to the renal cell carcinoma. The most common presenting symptom is hematuria. Suppose if the patient is having a visible hematuria. So in case of a gross hematuria or visible hematuria, which is also known as a macroscopic hematuria, there will be a demonstrable cause will be there for that hematuria in 50% of the cases, and 20% of the cases are related to the urogenital carcinoma. Either it may be related to the bladder, or it may be related to the ureter, or related to the kidney. So 20% of the cases are related to the urogenital carcinoma. If there is a microscopic hematuria, if the patient is having a microscopic hematuria, that means more than 3 or equal to 3 RBC per high power field, the chance of carcinoma will be less than 5%. But if the RBC is more than 25 per high power field, then greater malignancy risk will be there. So these are some of the important points that are related to the renal cell carcinoma. Sixth question, this is related to the undescended testis surgery. What is the status of processus vaginalis and what should be done to it? That means how you will tackle the processus vaginalis while doing the surgery for the undescended testis. So before we going to answer this question, let's understand what are the different phases of the testicular descent. So how this testicular descent is divided into 5 phases. The first phase, it will start at the 5 weeks of the age, where the future gubernaculum will comes in contact with the mesonephros at the inguinal ring, that is deep ring. At the 10 weeks of age, what will happen? The gubernaculum and processus vaginalis will be formed, and they will accompany the genitofemoral nerve. Because of formation of this processus vaginalis and the gubernaculum only, there will be formation of adequate passage for the testis to pass from intra-abdominal region to the scrotal region. So what will happen? The testis, actual growth of testis will start at 10 to 14 weeks of age, and gubernaculum will begin to swell at 14 to 20 weeks, that is phase 4, where there will be a migration of processus vaginalis, which will cause the widening of the inguinal canal, and the swelling of the gubernaculum. Because of the swelling of this gubernaculum, there will be deposition of extracellular matrix, which will lead to the formation of adequate passage, and the transinguinal passage of the testis. That means the testis coming to the scrotum will happen at 20 to 28 weeks of gestation. And once the testis has reached the normal location in the scrotum, then gubernaculum will undergo regression, and the processus vaginalis will also become obliterated. Suppose if this passage of the testis is not happened, then the patency of the processus vaginalis will be maintained. So this will be presenting as clinically inguinal hernia. According to this study, that is Sendron et al., which is taken from this information is taken from the Campbell, persistent processus vaginalis will be there in 87% cases of unilateral undescended testis and 71% of bilateral undescended testis. Now we'll go back to our question. So it is always present and should be left like that? No, it is not always present. It is always absent and nothing should be done to it? No, it is present most of the times. The option C is correct. It is mostly present and it needs to be addressed surgically because there is an associated risk of inguinal hernia, and this needs to be addressed surgically. So option C is the correct option. So what are the other anomalies that are associated with the undescended testes? The anomalies of the tunica. This will lead to the formation of the testicular torsion, and it will be difficult to differentiate the testicular torsion from the incarcerated hernia in a case of undescended testes. So it is very important to tackle this processus vaginalis at the time of the surgery for the undescended testis. So next MCQ, this is the question that is taken from Bailey and Love, that is given in the last NEET super specialty exam. So what is this characteristic sign? That is blue dot sign. This blue dot sign is characteristically seen in testicular appendage torsion. So what happens is this testicular appendage torsion, you cannot differentiate this with the testicular torsion in all the times. Suppose if you are able to differentiate from the testicular torsion, then no problem, you can treat that patient in a conservative way. But if you are not able to differentiate a testicular torsion with the testicular appendage torsion, that needs to be explored immediately surgically and needs to be corrected. So the most common structure to twist is the appendix of the testis, which is also known as a hydatid of Morgagni, visible through the scrotal wall as small dark spot. Okay, you can see the image here. This is the penis and this is the scrotum, where you can see the small blue color dot, which is known as which is called testicular appendage torsion, that is hydatid of Morgagni. If it is clinically diagnosed and if you are confident, then you can manage this one in a conservative way. But in case of a doubt, you have to perform surgical exploration and you have to remove the twisted appendage of the testis. Okay. Next question. This question actually, this is based upon the management of the metastatic carcinoma prostate. Here, 80-year male patient, he was diagnosed already. He is a known case of prostate carcinoma 3 years back, and he also underwent bilateral orchidectomy. So what is the information you are able to get from this bilateral orchidectomy? Means both the testes are already knocked out. That means the gonadal testosterone is already suppressed. Okay, But there is another source of testosterone in body, that is adrenal source, still it is present. But now this patient is presented with the multiple bone metastasis on X-ray pelvis, and PSA is rising trend. PSA is on rising trend. Okay. What is the drug of choice in this patient? Okay. The straightforward answer in this question, the drug of choice for the metastatic carcinoma, castration resistant. That means already this patient is castrated, still it is not responding. There is a progression of disease. So metastatic castration resistant prostate carcinoma, the drug of choice is docetaxel. Okay. So the drug of choice is docetaxel. So what are the different drugs that you have to understand? What are the different drugs that are used in management of castration resistant prostate carcinoma? The first drug that used is mitoxantrone. It will have a minimal palliative effect, but the mitoxantrone always, it should be combined with the low dose corticosteroids. It is usually for the patients who are very refractory to the docetaxel or cabzitaxel, which is the second line drug. The first one is, the first line of drug is docetaxel definitely, and cabzitaxel, this is the second line of drug. If the patient is having a poor performance status, if the ECOG score is more, or Karnofsky performance status is less than 50, in these patients there is a marginal performance status. So taxanes are toxic, and in these patients they won't tolerate the docetaxel. In those patients, you can go for this drug called mitoxantrone. So how this docetaxel has emerged as a drug of choice means, there is a study called TAX 327. There are some studies you need to remember for your exam. This is one such question that is very important study. This study has a study period of 30 weeks. This study, in which they compared the docetaxel and mitoxantrone, which is the best drug for the treatment of metastatic castration-resistant prostate carcinoma. In this, the docetaxel is given in IV form 3 weekly and every week also. The best overall survival is with the 3 weekly IV docetaxel, that is 75 milligram. And that the overall survival is around 19 months, which is much more than mitoxantrone. So this is how the docetaxel is concluded as the drug of choice for the treatment of metastatic castration-resistant prostate carcinoma. Another study is there. This is also important study. This is a landmark study, that is SWOG study, where the estramustin, oral estramustin, is given along with the docetaxel, and it is compared with the mitoxantrone, which is always given with the prednisolone. Some low dose corticosteroid, always it should be added to the mitoxantrone. So this is the study. The overall survival is better with the docetaxel compared to the mitoxantrone. But estramustin is ultimately, we have stopped this because of thromboembolic events. So docetaxel is given as a single drug only. It should not, the other combinations are also tried along with the bevacizumab and all, but the best is better to give the docetaxel as a single drug agent. Okay, these are the two important studies. So what is the next drug you have to understand? You have to know in a case of a metastatic castration-resistant prostate carcinoma is cabazitaxel. This is FDA approved, but this is a second line of agent. What is the study that has that leads to emergence of this drug is the TROPIC trial, where 750 men of metastatic castration-resistant prostate carcinoma who are progressed on docetaxel. That's why this is second line agent. First they have used docetaxel, but still the disease is progressing. So in this, the overall survival is better with the cabazitaxel compared to the mitoxantrone. You can see the overall survival is 15.1 months with the cabazitaxel, and whereas the mitoxantrone, the overall survival is 12.7 months, and the performance okay, and the performance status, progression-free survival is around 2.8 months with the cabazitaxel and 1.4 months with the mitoxantrone. So this is the study which has shown that cabazitaxel is the second line of agent. So what about the platinum-based therapy? So in case of a small cell neuroendocrine prostate cancers, which is also known as the aggressive variant prostate cancers, in those conditions, cisplatin can be used or carboplatin can be used. Cisplatin etoposide combination or docetaxel along with the carboplatin combination can be used. But remember, the first drug of choice for the treatment of metastatic castration-resistant prostate carcinoma is docetaxel. Second line agent is cabazitaxel. So why not goserelin in this patient? Like, see what happens is the goserelin will act upon the gonadal testosterone only. In this patient, already bilateral orchidectomy was done. That means there is no gonadal source for testosterone. The only source in this patient is adrenal gland. So goserelin will act only on the gonadal testosterone. So goserelin cannot be used. Paclitaxel, no. only the docetaxel is the treatment of choice. And next one is strontium. Why not the fourth option? This strontium is the drug previously used for the patients who are on having the bone metastasis and severe bone pains. In those patients, for palliation purpose, we used this strontium. But this strontium drug is also associated with the myelotoxicity. So, and there is a retention of this isotope significantly longer in patients who have diffuse osteoblastic metastasis. So, this we have discontinued this strontium. In the place of strontium, we are using radium 223, or we are also using the zoledronic acid and bisphosphonates. So those are better for the palliation of the palliative treatment for the bone pain. Okay, so these are the other options in this question. I hope I am clear. Next, we'll go to the ninth question. What are the contraindications for the living donation? Okay, living kidney donor. BMI more than 40, yes, it is contraindicated. Active malignant disease, it is a contraindication. Schizophrenia, it is a contraindication. And last one is GFR, if 80 ml per minute, that is not a contraindication. If GFR is less than 70, that is the contraindication. So this question is taken from the Sebastian textbook of surgery. So BMI more than 40, diabetes, active malignant disease. Okay, if there is active malignant disease, GFR less than 70, if there is a significant albuminuria, hypertension requiring multiple medication. So here they can ask you as a question like, if the patient is a known hypertensive and he is using a single drug, that means single drug, if he is able to control his hypertension, then that patient can donate kidney. He is a potential donor. Okay, so next one is horseshoe kidney and pelvic kidney. These will have a different anatomy. That means you cannot know the number, how many arteries are there. Aberrant blood supply will be there. So it is difficult in this patient. So this is a contraindication. If there is significant psychiatric impairment, then that patient also not eligible for donation of the kidney. If there is a nephrolithiasis and there is a high chance of recurrence. Suppose if there is a nephrolithiasis, single stone is there in the donor kidney, but if the patient is metabolically not having any complications, in that patient you can go for the donor nephrectomy. But if there is a high chance of recurrence, if the patient is forming the cystine stones or struvoid stones, in those conditions, this is a contraindication for the living donation. What is the some of the important questions that are related to this topic are the standard age, standard criteria for the living donation. The age will be less than 35 years, but extended donor criteria up to 60 years also you can include for the kidney donation. So schizophrenia is not an absolute contraindication, but if he is well controlled on medication therapy and if there is a better compliance with the patient, if he is adherent to the strict psychiatric plan, patient is adherent to that plan and he is willing to donate the kidney, then you can go for the donation in schizophrenia also. But if it is poorly controlled psychiatric illness, then significant psychiatric impairment is there, then it is a contraindication for the donation. The next question, this question is based upon the HLA antigens mismatch in organ transplantation. So what will happen? These HLA, this allograft rejection is directed against these antigens. Okay, these are group of cell surface glycoprotein molecules. These HLA molecules are categorized into two classes, class 1 and class 2. Class 1 means HLA A, B, and C, whereas a class 2 means HLA DR, DP, and DQ. These class 1 molecules are located on all nucleated cells, whereas the class 2 molecules, these class 2 HLA molecules are located on antigen presenting cells, that is dendritic cells and B lymphocytes only. So these HLA A, B of class 1 and HLA DR of class 2. Okay, HLA A and B of class 1, HLA DR of class 2, these together are known as the tissue type, and the level of mismatch of these HLA bodies so will determine the strength of the immune response. So if there is a best match, there is no mismatch. Best match graph means 0, 0, 0. That means the 2 copies of each gene will be there for the each locus, and there is no mismatch at all between the HLA A, HLA B, and HLA DR. That is the best match graph. If there is a complete mismatched graph, that means 2, 2, 2. That is called complete mismatch. So the DRA mismatch will have more powerful DR. The DR mismatches will have more powerful effect compared to the B mismatch and A mismatch. And A mismatches are of least important. So the answer will be DR greater than B and A, because the DR mismatches are more powerful followed by B mismatches, and the least powerful mismatch is A mismatch, HLA-A mismatch. So this is the question based upon the HLA antigens. So the last question, this is much more of a theoretical question. What happens? This patient, 30 years male, underwent radical orchectomy. Remember one thing, always the pathological staging of the testicular tumors is after surgery only, after the primary surgery. So the radical orchidectomy, it comes under the initial evaluation of the patient only. Okay, the radical orchidectomy always comes under the initial evaluation of the patient only. The actual treatment starts after the surgery, because you will be able to get the proper diagnosis. You won't be able to get do the biopsy in a testicular carcinoma, so you will get the proper diagnosis after the surgery only. So in this patient underwent radical orchidectomy, there is a pathological examination has revealed that tumor is limited to testis and epididymis, and there is no vascular or lymphatic invasion. They asked about the pathological stage of the tumor. If there is no, without vascular and lymphatic invasion, means it is pathologically T1. So TX means the primary tumor you cannot assess. T0, there is no evidence of any primary tumor. Or TIS, there is an intratubular germ cell neoplasia. PT1, here the tumor is limited to the testis and epididymis, but there is no vascular or lymphatic invasion, and tumor is invited into the albuginia, but not the tunica vaginalis. But if the tunica vaginalis is involved, then means PT2. Here the tumor is associated with the vascular and lymphatic invasion also. If the spermatic cord is involved, it is T3. If the scrotal wall is involved, the scrotum is involved, then is pathologically T4. T3 and T4 doesn't matter whether the vascular or lymphatic invasion is present or not. So this is about the TNM, pathological staging, pathological T staging of the testicular tumor. These are the questions from the last year NEET super specialty examination. If you have any doubts, you can reach out on this mail ID. Okay. Anyone, any doubts, you can reach out on this email ID. So next session will be on the oncosurgery. Dr. Dorian sir will be taking the session on the different, what are the last year 2023 oncosurgery questions. Okay. Thank you.
Thank you, sir.
Thank you, sir. You can continue with your class, sir.
Yes, just a minute.
Thank you, sir.
So is my screen visible? So is my screen visible?
Yes, sir.
Okay, am I audible?
Yes, sir. Good to start, sir.
Yes.
Sir, please unmute yourself. Sir, please unmute yourself.
Am I audible now?
Yes, sir.
Am I audible? Okay. Yes. So good evening, everyone. This second part of today's session will be regarding the questions asked in OncoSurgery, that is from various cancers. Okay. In last year's NEET 2023 question paper. So some of you would have attended the last year's exams, and you would have been in your second year of preparation. So this will be just a revision to you, and for others and for everyone else, I do sincerely hope that you have prepared well, and everything I'm going to tell will be just a revision to you. If not, the things which I'm telling you will be helpful to you for rapid learning of the facts. Okay, so let's go to the topic. Yes, the first question was a 45-year-old female presented with a right breast lump to OPD. On examination, she had a 4x4 centimeter lump in the upper outer quadrant with a right axillary lymph node of 1.5 centimeter size, for which FNAC was done. FNAC was negative. Okay. The core needle biopsy from the lump was IDC NOS type. The mammogram was taken then, which showed the following two features: architectural distortion and diffuse microcalcifications. What will be the best treatment option for her? Okay. So these were the four options. Actually, some of the options may not be right as to what was given in the last exam. The faculty have made our own options in order to make you learn. Okay. The options given here are breast conservation surgery, modified radical mastectomy, neoadjuvant chemotherapy followed by breast conservation surgery, and neoadjuvant chemotherapy followed by modified radical mastectomy. So in this question, I've discussed all the points regarding to screening mammogram and what to do when a mammogram gives such a picture. Okay. So there are two screening recommendations given in Sabiston. The first recommendation is by the United States Preventive Services Task Force, which states that women in the age group of 50 to 74 should be offered a biennial mammogram, that is twice mammogram every year. Okay, every 6 months she must undergo a screening mammogram. But the American Cancer Society says that any women above the age of 40 should be undergoing a screening mammogram, and this should continue as long as the woman is in good health. Okay, the American Cancer Society recommends only an annual mammogram, not a 6-monthly mammogram. So this recommendation, this American Cancer Society recommendation, is what we follow in our country, India. Okay, so they are more likely to ask this. In India, the mammogram is taken above the age of 40, and it is continued as long as the woman is in good health, and that should be the answer. Okay. So what are the two views in a screening mammogram? Mediolateral oblique view and a craniocaudal view. Mammograms can be asked sometimes as an image-based question. So I'm going to discuss two slides regarding each view. So this is the mediolateral oblique view. The name MLO, mediolateral oblique view, implies that the X-rays are projected from the medial side of the breast, and the film cassette is kept on the lateral side of the breast. Okay, mediolateral oblique. So this is a classical mediolateral oblique view of the left breast. The X-ray is projected from the medial aspect, and the plate is kept on the lateral aspect. So this is the craniocaudal view. Again, the name implies, craniocaudal implies the X-ray is projected from above and the plate is kept below. This is the craniocaudal view. So the craniocaudal mammogram will be like this. How to differentiate? The mediolateral oblique view will be always having the pectoralis major in the left side of the film, or the posterior aspect of the film. Whereas the craniocaudal view will not be having the pectoralis major at all. Okay. So Sabiston gives the following figures for reduction in death if a proper screening mammogram is done. In the ages of 39 to 49, if a regular screening mammogram is done, the reduction in death from breast cancer will be 15%. In the ages of 50 to 59, the reduction will be 14%. And in the ages of 60 and above, the reduction will be 32%. So the maximum reduction is seen in this age group. Okay. So what are all the mammographic features that suggest malignancy? A solid mass, architectural distortion or asymmetrical thickening, stellate features. Stellate means star-shaped. Okay. Clustered microcalcifications. And I've put some pictures of different malignant calcifications because they can be asked as an image-based questions. So this is a coarse heterogeneous. Coarse means the size should be more than 5 mm. That is the mammographic cutoff. Okay. So this coarse heterogeneous calcification, about 10 to 15% of such calcifications may have malignancy risk. And these are fine pleomorphic calcifications. So pleomorphic means various shapes, but the size should be less than 0.5 mm. That is, coarse means more than 0.5 mm, less means fine means less than 0.5 mm. They have an even higher risk, up to 25 to 40% risk of malignancy. And this is the last type of malignant calcification. They are the fine linear or branching calcification. You can see this linear types. It starts here and there are 3 branches going on. No. So this is the fine linear calcifications. They have the highest risk of malignancy, about 70%. Even this can be an MCQ by itself. The highest risk of malignancy is with fine linear or branching calcifications. So this is the stellate mass. They can ask even this picture also. Stellate means star shaped. See, you can see the various arms of the star. Okay, so stellate mass always implies malignancy. So you all know this BIRAT score, BIRAT 0, 1, 2, 3, 4, 5, 6, and they can ask the risk of malignancy in each BIRAT score. They will usually ask this 4 only, okay, because 4 is divided into 3 types, 4A, 4B, and 4C. 4A has up to 2 to 10% risk, 4B has 10 to 50% risk, and 4C has 50 to 95% risk, okay. So you need to know the percentage of malignancies. So mammogram used for screening is over. How and when you should use MRI for screening? Okay, they can ask that also. So this table is taken from Sebastian, and American Cancer Society recommends the usage of MRI for the following conditions. The patient has a known BRCA1 or 2 mutation, or he or she is a relative of BRCA1 2 mutation patients. The lifetime risk of breast cancer is 20 to 25%. Usually this is CQ. The lifetime risk will be 20 to 20% or more. And if the patient has received radiation therapy to the chest between the ages of 10 to 30, and if the patient is a known case of Li-Fraumeni syndrome or Cowden syndrome, or he or she is a first degree relative of any person with these syndromes. Okay, so in all these conditions, you have to use MRI for screening rather than screening mammogram. Okay, so the screening mammogram is over. In order to know the correct answer for the question, we must know what are all the contraindications for breast conservation surgery. The absolute contraindications are, I used to remember with the letter P, okay, pregnancy, polycentricity, which means multicentricity, persistently positive margins, okay. Persistently positive margins means even after repeated attempts, the margins after BCS are coming as positive. When such a condition occurs, you cannot do BCS indefinitely, okay. You cannot go on excising the margins. You have to go to mastectomy at some point. So what is that some point is? 3 times persistently positive margins is an indication for mastectomy. 3 times. Prior irradiation, because you cannot irradiate the breast again after BCS if you have already irradiated the chest wall, and if the patient wants breast, do not want breast conservation. The other important contraindication is diffuse malignant appearing microcalcifications, and inflammatory breast cancer is a contraindication for breast conservation. So these are all the contraindications for radiation, okay. So you remember, after all breast conservation surgery, you have to give radiation mandatory, because you have not removed the organ, you have just removed the tumor. You have to give radiation mandatory. So these are all the contraindications for radiation. So all these will become relative contraindications for breast conservation surgery, okay. So coming back to the question, look at this mammogram. This exact question was given for only for this word alone, diffuse microcalcifications, okay. If a single foci of microcalcification is present, the patient is suitable for breast conservation surgery. If there are multiple microcalcifications all over the breast, he is not suitable for breast conservation surgery, as one or other of the microcalcification may be harboring malignancy. So diffuse malignant appearing microcalcifications, you must do MRM, modified radical mastectomy. The other 2 options, neoadjuvant chemotherapy, is not carried out because of the size, okay. 4 × 4 centimeter, the tumor will come to T2 size, okay. For T2, you can go for upfront surgery, no need of neoadjuvant chemotherapy. So the correct answer will be option number B, modified radical mastectomy, because the patient has diffuse malignant appearing microcalcifications, okay. The next question. The most common paraneoplastic syndrome seen in bronchogenic carcinoma, okay. The following options have been given. I've searched for Bailey, Sebastian, and Schwartz. None mentions the most common paraneoplastic syndrome. But inside the text, a few points are given. Bronchogenic carcinoma, this table you can just go through, no need to mug up everything. Bronchogenic carcinoma can be divided into 2 types, squamous cell carcinoma and small cell carcinoma and non-small cell carcinoma. Okay. Small cell carcinoma usually cause endocrine paraneoplastic syndromes and neurologic paraneoplastic syndromes. So in this table, there may be multiple neurologic and multiple endocrine symptoms. All this can be caused by small cell lung cancer. Non-small cell lung cancer can cause hypercalcemia, hypertrophic pulmonary osteoarthropathy, and cutaneous manifestations. Okay. So if you compare small cell and non-small cell, the most common lung cancer will be non-small cell all over the world. And the most common paraneoplastic syndrome caused by non-small cell lung cancer will be hypercalcemia. So the option for this question will be most probably hypercalcemia. They can ask, what is the most common paraneoplastic syndrome associated with small cell lung cancer? So the most common paraneoplastic syndrome associated with small cell lung cancer will be this option number 3, syndrome of inappropriate secretion of antidiuretic hormone, SIADH. The characteristic biochemical feature will be hyponatremia, euvolemia, and normal osmolarity. Okay, euvolemic normal osmolarity with hyponatremia will be the characteristic feature of SIADH, which is the most common paraneoplastic syndrome caused by the small cell lung cancer. Okay, so if you have any doubts, you can post in the one person, Dr. Abhishek Gupta, had asked, do we do only MRI or MRI plus mammography? For the table which I have put as the indications for MRI, for those cases, only MRI is sufficient. Okay, MRI is superior to mammography. Since it is not cost effective, we do not follow in all patients. If you take MRI, it is enough. No need for mammogram. For all other patients do not belonging to the table, you take mammogram alone. Okay, hope your doubt is cleared. If you have any doubt, am I audible now? Most of you are putting that I'm not audible. Am I audible? I have just unmuted myself. And I hope someone replies in the chat box whether I am audible, okay? So that I will be able to know. Am I audible well? Okay. So for all cases, you do mammogram alone, except for those cases mentioned in the table, you do only MRI. Okay, thank you, sir. Only MRI. If you do MRI, mammogram is not necessary. Okay. If you have any other doubts, you can just post in the chat box in the YouTube link. I'll be replying to that live. Okay. So this question, the answer will be, since the most common bronchogenic carcinoma will be non-small cell lung cancer, the most common malignant, paraneoplastic syndrome will be hypercalcemia. Okay. So most common type of lung cancer, it's not small cell, sir. It will be non-small cell only. You have to see all other cancers like squamous, adeno, everything. All other things, large cell carcinoma, all these 3 things will come under non-small cell carcinoma. When you take as a combined thing, the most common will be non-small cell carcinoma only. Most common type will be non-small cell. Small cell is not common. Okay. So the next thing will be sessile serrated adenomas can progress to carcinoma by all of the following pathways, except, leave alone the options. For this, if you take colon cancer chapter in Sebastian, they have given 10 pages regarding the molecular analysis of colorectal cancers. I've tried to compile them in all to 5 to 6 slides, all important points, all MCQ points. Okay. We will just discuss them. Actually, you all know about the adenoma carcinoma sequence. Okay. Fearon-Vogelstein sequence. About 80 to 85% of colorectal cancers, colorectal adenomas progress to carcinoma by adenoma carcinoma sequence. Okay. You all know that. You all know what are all the genes mutated in that APC gene, KRAS gene. Okay. Deleted in colorectal cancer, DCC gene. Okay. All these are mutated there. Leave that. That is not important. They won't ask questions from that. That is for UG level. They will ask questions in the remaining 15% only. So the remaining 15% of colorectal cancer is called euploid colorectal cancer. Because in this euploid colorectal cancer, the APC gene is not mutated. There are 2 copies of APC gene. Okay. So since there are 2 copies, they call it as euploid colorectal cancer. See the first point, there are no APC deletions. In the cancer genome atlas classification, it is coming under hypermutated category. They may ask, the TCGA classification is given in Sebastian. So you need to know that TCGA classification is also given for carcinoma stomach also. Okay, it's the latest advance. They may ask in exam. You have to read it for stomach and for colorectal cancer. Okay. So there are 2 types of euploid colorectal cancer. First is due to defective mismatch repair gene mutations. And second is mismatch repair gene epigenetic silencing due to SIMP phenotype. What is this SIMP? CIMP is CPG, cytosine guanine island methylation phenotype. Okay. Anything related to methylation will come under epigenetic silencing. Okay. So these colonic adenomas will be having, every cell will be having its own DNA. No. So this particular type of adenoma will be having this excessive amount of cytosine and guanine in between their DNA sequences. Okay. Rather, when compared to the normal cells, they will be having excessive CPG islands. These CPG islands will be methylated, leading to their irregular growth and cancer. Okay. So among this 15%, 5%, that is 1/3 of euploid colorectal cancers are familial, and that syndromes you know as hereditary non-polyposis colorectal cancer. Okay. 1/3 of euploid colorectal cancer is syndromic and it is HNPCC. And what is microsatellite? Microsatellite means repeat, there will be 6 to 30 base pairs. Okay. 6 to 30 base pairs. These base pairs will be identical in all the cells, in all the organs of a particular individual. Okay. The sequence of this 6 to 30 base pairs. Okay. It will be identical in all the genes, in all the cells, in all the organs of that person. It is called as the genetic fingerprint of that patient. Okay. When this mismatch repair genes are mutated, this genetic fingerprint or the microsatellites are altered, leading to the development of thousands of insertions or deletions or mutations in the microsatellites. This is known as microsatellite instability. Okay. The person's genetic fingerprint is lost. The 6 to 30 base pairs will be unique for each person. Okay. So this is the first thing will be the adenoma carcinoma sequence. The second thing will be the euploid colorectal cancer. Okay. So what will be the phenotypical correlation for this euploid colorectal cancer? These are all the characteristic features they may ask as MCQ. The euploid colorectal cancer is most probably likely to be arising in the right side of the colon. The patient will be of older age, most commonly arising in females. There will be a higher frequency of BRAF, that is V600E mutations, and there will be an accelerated progress from adenoma to carcinoma. You all know that in familial adenomatous polyposis, the initiation of the polyp will be very rapid, whereas for the polyp to progress into a carcinoma, it needs 15 years. Okay. So when a child is born, it will have polyp in FAP. For it to turn to cancer, it will take around 25. When the child reaches 25 years of age only, it will turn into cancer. So you have that window where you can carry out repeated screening. And after 18 years of age, you can carry out this total proctocolectomy. Okay. The same thing cannot be applied in HNPCC. In HNPCC, the initiation of the adenoma is what is delayed. Patient will get adenoma only by the age of 40 or 45. You don't know if he is having mismatch repair gene defect at all. You cannot screen all the persons in all the world for HNPCC. Persons will get adenoma only by the age of 40, but once after getting, there will be an accelerated progress to carcinoma. So most commonly, these HNPCC patients present to us with carcinoma, whereas the FAP patients present to us with adenomas. Okay. And the tumors in HNPCC will be very large. The tumors will be poorly differentiated, associated with mucinous or signature cell histology. There may be associated tumor infiltrating lymphocytes. Usually, despite this large tumor, which what is euploid, sir? Euploid means there are 2 copies of the gene. Okay, 2 copies of the chromosome. In adenoma carcinoma sequence, the first gene to be lost is FAP gene, that is this APC gene in chromosome 7, that is mutated initially itself. In childbirth itself, it is mutated. Okay, so the child will be having only a normal, that is only 1 copy of normal APC gene. So it is not euploid. Okay, it is not euploid. In HNPCC, there will be no genetic loss, hence it is called euploid. Okay, that is the number of chromosomes are normal. The euploidy means it is a highly advanced organism. In humans, the type of euploid is diploid. Okay. If the euploid is lost, it is called as aneuploidy. Okay. That's all you have to know. I hope I am clear and I have cleared your doubt. Okay. So despite a large local tumor with poor tumor differentiation and mucinous histology, these tumors will have a better prognosis. Okay. You all know that if there is a mucinous or signature cells in any cancer, there will be a poor prognosis, but here there will be a better prognosis. So this can be asked as an MCQ. And the classical agent given for chemotherapy for carcinoma colon is 5-fluorouracil, but this euploid colorectal cancer will be resistant to 5-fluorouracil. but they will respond better to PD1, that is programmed cell death 1 blockade. Okay, so all these are given in Savastan and Schwartz. They may be asked as MCQ. Just a minute, I'm unable to move my slide. Yes. So this diagram is given in Savastan. You see this adenoma carcinoma sequence. So this is the adenoma carcinoma sequence. Here, there will be no mismatch microsatellite instability high. Okay. All are MSS, that is microsatellite stable. Microsatellite stable. There will be only 5% where there will be microsatellite instability high. They will also come under this classic adenoma carcinoma. I mean, they will have this classical adenomas. Okay. Our question is regarding this serrated adenoma pathway. Okay. This serrated adenoma pathway will have SIMP plus microsatellite stable or SIMP plus microsatellite instability high. Okay. See this 13% of serrated adenomas have microsatellite instability high. Okay. Don't worry if you don't understand this diagram. This is just to elucidate that colorectal cancer genetics is a highly heterogeneous topic. That's what they have tried to compile. Our question, and the examiners also know this. That's why they have asked this question. No need to read about all this. Okay. Just see this table. This is the diagnostic criteria for hereditary non-polyposis colorectal cancer. First, initially, they gave this Amsterdam 1 criteria. You remember it as 3-2-1. 3 relatives with colorectal cancer. 1 relative should be a first-degree relative of the other 2. At least 2 successive generations should be affected. And at least 1 colorectal cancer should be diagnosed before the age of 50. Why? In HNPCC, there will be delayed adenoma. The adenoma will be forming only by 50. By 51, he will develop cancer. In FAP, the adenoma will be forming by childhood. He will develop cancer only by the age of 25. Okay, so that is the difference between these two. And FAP should be excluded and the tumors should be verified histopathologically. So later, they found out that this HNPCC doesn't include only colon cancer. Lots of other extracolonic cancers are also there. That's when they gave this Amsterdam 2 criteria. It will include other cancers also, which are related to colorectal cancer. I mean, which are non-colorectal cancers, but associated with HNPCC. I used to remember all these other cancers by the mnemonic CESUR, seizure, given by our beloved Dr. Raja Mahendran sir in his classes when I was a student of him. Okay. Seizure stands for CESUR, C for colorectal, N, E for endometrial, S for stomach and small bowel, U for ureter, and R for renal pelvis. CESUR are the other cancers related to HNPCC. And again, the same 3-2-1. 3 relatives, 2 generations, 1 should be before 50, FAP should be excluded, and tumor should be verified histopathologically. Okay. This is Amsterdam 2 criteria. And this Bethesda criteria is for suspicion of any patient with colorectal cancer. You should suspect him to be having this microsatellite instability high. So who are all these patients? You have to mug up this table. And in all these patients, genetic testing is validated for microsatellite instability. Okay. So Amsterdam 1-2 criteria. Amsterdam 1 is for colorectal cancer, 3-2-1. Amsterdam 2 is for seizure cancers, 3-2-1. And again, Bethesda is for genetic testing of all these patients. You suspect them of having HNPCC and you subject them to genetic testing. Okay. So coming back to our serrated polyps. What are serrated polyps? Serrated polyps have a sawtooth configuration and nuclear atypia. And this only one line is given in Savastan. Okay. For this one line, they have asked that question. And you have to read all those 10 pages. So that's why I took such a long presentation for this genetics of colorectal cancer. So it will be easier for you. Serrated polyps do not follow adenoma carcinoma sequence in transforming into malignancies. Okay. So coming back to the question, sessile serrated adenomas can progress by all of the following except SIMP. You know what is SIMP? MSAIH, you know, BRAF, you know, it is mutated in colorectal cancer. Adenoma carcinoma sequence, 85% of colorectal cancer. Traditional adenomas, no sessile serrated adenomas. So the answer will be adenoma carcinoma sequence. Okay. So if you have not studied colorectal cancer in genetics, need not go back and study. Just read all these slides. They are enough. Okay. So this once more, I was surprised with this question. This question is based on only one line from Schwartz. Okay. Schwartz, you know, it will be very difficult to read. And inside the Schwartz, in chemotherapy and targeted therapy, only one line is given. For that one line, they have asked this question. Okay. Drug, it is not given in Savastan. Drug which acts on both HER2 and EGFR. Okay. So this is related to breast cancer. So these are some of the drugs targeting HER2/neu. Okay. So you all know that breast cancer treatment is currently based on prognostic markers, ER, PR, and HER2/neu. So what any marker is targetable, you target those mutations. And all these drugs are based on HER2 mutations. So the mechanism of action, it is given in both books, Savison and Schwartz. So I put up. So this HER2/neu targeted therapies, it's a very important topic, and it is quite a recent advance, and it is likely to be asked in every exam henceforth. At least one question you can expect, because you know what was the most purchased cancer drug last year in 2024? You know, the most purchased cancer drug in 2024 was adotrastuzumab emtansine. Okay, one of the HER2 targeted drug for breast cancer, adotrastuzumab emtansine, manufactured by Merck company, was the most purchased cancer drug in 2024 by doctors. Okay, so it's such a good topic, and it is more likely to be asked in exams. Trastuzumab prevents HER2 homodimerization. So what is the meaning? Means breast has 3 prognostic biomarkers, ER, PR, and HER2. Estrogen receptor and progesterone receptor have something to bind with them. Okay, to the estrogen receptor, estrogen will come and bind. To the progesterone receptor, progesterone will come and bind. To the HER2/neu receptor, there is nothing to bind. So how will the HER2 promote growth? Means it will bind to some other HER2 receptor. I have no one to give me anything. I will go and join with my friend. Okay, this HER2 will bind to another HER2 receptor, and that's how they transmit signals. Okay, so trastuzumab prevents HER2 homodimerization, that is HER2 plus HER2 combination. Adotrastuzumab emtansine is an antibody drug conjugate. Here they have trastuzumab and emtansine, which is another anti-cancer drug, which is a microtubule inhibitor like paclitaxel and docetaxel. So this adotrastuzumab emtansine is an antibody drug. There is another drug targeting HER2 called pertuzumab. It is also given in Sabiston. Pertuzumab prevents HER2 heterodimerization. Okay, pertuzumab prevents HER2 heterodimerization. That is combination of HER2 plus HER3. Okay, lapatinib. This only one line is given in Schwartz, not given in Sabiston, given in Schwartz. Lapatinib blocks HER2 and epidermal growth factor receptor. It's a combined blockade of epidermal growth factor receptor and HER2. It is approved in the metastatic setting alone, along with capecitabine. Okay. So I've also put up in what all settings, what all HER2 directed therapies are approved. Trastuzumab plus pertuzumab combination, the drug is called Phesgo, 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 is approved in all settings, neoadjuvant, adjuvant, and metastatic. Trastuzumab plus neratinib. Neratinib is another drug, another HER2 targeting drug. It is not given in books what is the mechanism, so you need not know. It is just given that it is approved in adjuvant setting. Lapatinib, which we have just now seen, EGFR plus HER2 blockade, is approved in metastatic setting. TDM1, that is adotrastuzumab emtansine, is approved in the metastatic setting and in post-neoadjuvant chemo residual disease. So you do a neoadjuvant chemo to a patient. Example, you take the patient of the first question. Imagine if she is having a 6x3 centimeter tumor, T3N1, prognostic marker HER2 positive. So you have to treat her with neoadjuvant systemic therapy. You treat her with this trastuzumab. So post-trastuzumab, you do MRM, modified radical mastectomy. In that MRM specimen, if a residual disease is there, you should not give Herceptin, that is trastuzumab again. You have to give adotrastuzumab emtansine. You have to upgrade your treatment. This thing is given in Schwartz. You have to upgrade your treatment. For that upgradation, you give TDM1. Okay, that's why I have written post-neoadjuvant chemotherapy residual disease. Okay, so Schwartz and Sabiston combined, I have given around 5 to 6 trials for HER2 directed therapies in breast cancer. I have compiled all this and put here, so you need not just search for them. The first is HERA trial. HERA stands for Herceptin adjuvant. It proved that 1 year of adjuvant trastuzumab is sufficient. No need to give for 2 years. 1 year of adjuvant trastuzumab is sufficient. One landmark trial, DCIRG 006. It gave the importance of this TCH regimen when used in the neoadjuvant setting. So Herceptin is usually combined with any chemotherapy because the combined effects of chemotherapy and Herceptin will destroy the cancer cells even more effectively. So the neoadjuvant regimen followed in a case of HER2 positive breast cancer, nowadays standard of care from the last 6 to 8 months, okay, is BCIRG-006 trial-based TCH regimen. T stands for docetaxel, C stands for carboplatin, H stands for Herceptin. Okay, so TCH regimen is a landmark trial. The landmark trial which gave this regimen was BCIRG-006. It is the current standard of care for neoadjuvant Herceptin. The next trial is Trifina trial, which gave the usage of trastuzumab plus pertuzumab combination in the neoadjuvant setting. Affinity trial, which gave the combination of trastuzumab plus pertuzumab in adjuvant setting. A for A. And the next trial will be this Catherine trial, which we have discussed now. In post-neoadjuvant chemotherapy, residual disease after surgery, you should not just give trastuzumab alone. You have to give TDM1. You have to upgrade your treatment, which was given by this Catherine trial. Okay, so these are all the HER2 related trials given in Sebastian and Schwartz. So coming back to the question, drug which acts on both HER2 and EGFR is lapatinib. Okay. So the next question, the question shared by last year's attendees was NSAID protective against cancer. We do not know the options. So I have searched for answer for this question in Sebastian, Schwartz, and Shackelford. No need to worry. This is all the answer for this question. For chemo prevention of cancer, NSAIDs are recommended only in duodenal and colorectal cancers. Okay. For duodenal cancers, the drug which is used is erlotinib. Okay, erlotinib, which is an EGFR inhibitor. For colorectal cancers, the drug of choice is Sulindac, 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 which suppresses colorectal adenomas and also desmoid tumors. The other drugs which can be used are difluoromethylornithine and celecoxib. Okay, difluoromethylornithine, celecoxib. These 4 drugs names only are given in all the books. Just mug up these 4 names alone. So they'll be asking what are all the drugs that can be used, all except something like that. So you remember these 4 drugs. Okay. So I'll be happy to answer in the chat box. You can ask any questions you want. Okay. Excuse me. So next question will be, which is the false statement regarding liquid biopsy? Okay, liquid biopsy is again a recent advanced topic. It is given both in Sebastian and Schwartz. It is useful for screening. HPV DNA can be used to diagnose carcinoma oropharynx. It is useful for prognosis and it's useful for identifying distant metastasis. So there are 2 terms in cancer: circulating tumor cells and circulating tumor DNA. One is given in Schwartz, one is given in Sebastian. I have combined both. Both of these can be detected by liquid biopsy. So what is liquid biopsy? So what is solid biopsy? Solid biopsy means we take a biopsy from the tumor. Liquid biopsy means take a biopsy from the blood. That's all you have to know. You are taking biopsy from the blood. In the blood, you detect either tumor cells or tumor DNA. Okay. So it is approved currently for carcinoma nasopharynx and carcinoma colon diagnosis. It is not approved for any other things. It can also be used for screening because certain times the patient will be presenting with just a lymph node without any identifiable primary. In such cases, the circulating tumor cells can be identified, and from there, the primary can be identified. One cancer assay has been evaluated and found to be suitable for that. I will be putting it in the slide. What is circulating tumor DNA? It is given in Sebastian. It is also known as cell-free DNA. That is, the cancer cell loses its DNA. The DNA comes out of the cancer cell and it is circulating in the blood. This circulating DNA is picked up by multiple tests by liquid biopsy. Okay. The DNA is shed from the cancer cell due to several factors. First is necrosis, next is phagocytosis, next is apoptosis. Okay. This circulating cell-free DNA can be used as a tumor marker, especially to determine the site of origin of unknown tumors. And this was the assay, CancerSeek. Okay. CancerSeek used this circulating tumor DNA. This can be asked as an MCQ. What does CancerSeek use? RNA, DNA, circulating cells, microRNA. The answer will be DNA. Okay. And this had a sensitivity of up to 98% and specificity of 99%. Okay. So which of the false statement is? HPV DNA can be used to diagnose. You cannot diagnose carcinoma oropharynx by liquid biopsy. Currently, it is approved for nasopharynx and CA colon alone. Okay. So what is this ERAS protocol? The next question will be based on ERAS protocol, enhanced recovery after surgery, which is the false statement. Early initiation of orals, avoiding nasogastric tube, epidural analgesia, and opioid analgesia. Okay, so what you have to remember is, even though ERAS stands for enhanced recovery after surgery, it is not just the modalities carried out after surgery. The ERAS starts even before the patient is posted for surgery. Okay, so this answer I've taken from the original paper by Henrik et al. Henrik et al. Gave the following things or the following methods to be followed for ERAS protocol. ERAS, as I mentioned, starts before surgery. So what are all the preoperative things? Patient should be educated. The patient should be optimized. His anemia, coagulopathy, protein or electrolyte disturbances, hydration disturbances, all should be corrected. Bowel preparation is generally avoided. Antibiotic prophylaxis is given. This is the most important preoperative guideline. Solid foods can be given up to 6 hours before surgery. Even for a case of carcinoma stomach or Whipple's procedure, you can give solid foods up to 6 hours prior surgery. Carbohydrate-rich fluids, liquids can be given up to 2 hours before surgery. Current recommendation, so use it. Adequate hydration is useful. Intraoperative maneuvers like optimal fluid management, no pre-medication, short-acting anesthetic agents, epidural, non-opioid analgesia, and maintenance of normothermia. Okay, normothermia means do not allow the patient to become hypothermic. All these are the responsibility of the anesthetist during surgery. Usage of minimally invasive surgery, preferably, and minimal usage of drains, catheters, and tubes. These two are responsibility of the surgeon. In post-operative, there should be no Ryle's tube or early removal of Ryle's tube, early initiation of orals, active management of nausea and vomiting. Again, in the post-operative period also, you use non-opioid analgesia in the form of epidural analgesia, preferably patient-controlled analgesia. Okay, so the patient can be controlling the amount of drops in the IV fluid containing analgesics. Okay, if he feels more pain, he can use to increase. If he doesn't feel any pain, he can reduce. Okay, and early Foley's catheter removal, early mobilization, and thromboprophylaxis. All these are components of ERAS protocol. So the false statement here will be option D, opioid analgesia. Opioids are not used for ERAS protocol. Don't get confused. Opioids are good analgesics, very good analgesics, but not used in ERAS protocol. Okay. Practice and studying is different. After your super specialization, you will be practicing, you will be using opioids left and right, believe me. But this is your exam, avoid opioids. Okay. The next question will be, prophylactic thyroidectomy in men 2A is done at what? 1 year, before 1 year, 5 years, before 18 years. So see this table from Sabiston. You just need to know these first 3 things alone. So these are all the mutation codons. So nowadays, in all cases of medullary thyroid cancer, you need to do RET mutation analysis. Okay, very important. Earlier, it was recommended only in syndromes men 2A and 2B. Nowadays, it is recommended for all cases of medullary thyroid cancer. Okay, so if you get a case of medullary thyroid cancer, you identify the following mutation in any of these codons. If it is in the 918th codon, it is synonymous with men 2B, and the patient is placed in the highest risk category. Any of these 3 can be asked regarding the duration. Okay, HST gene mutation, when will you do thyroidectomy? They will ask. Okay, HST means highest risk. Okay, in highest risk, the age of thyroidectomy should be less than 1 year. The codon 634, which is synonymous with men 2A, but placed under high risk, and 883 mutation, synonymous with men 2A, placed under high risk, the thyroidectomy should be done before 5 years. Okay. All other mutations, need not remember any of these numbers. All other mutations, the thyroidectomy is done greater than 5 years of age. Okay. Remember these 3 alone. So again, you have to remember when to start screening for pheochromocytoma also. So in case of men 2B or highest risk ATA, you begin screening for pheochromocytoma at 11 years. Okay. And men 2A high risk. Okay. Again, in Sabiston, it is given as same as above, which means 11 years. Okay. All these other genes, other codons, you begin screening at 16 years of age. Very important. Okay. Very important. Men 2B begin screening at 11 months of age for pheochromocytoma, 11 years of age for pheochromocytoma. Men 2A, both these codons begin screening at 11 years of age for pheochromocytoma. All these other codons begin screening at 16 years of age for pheochromocytoma. one important concept. Where will you implant the parathyroid if you accidentally remove it during total thyroidectomy for any of these conditions? In men 2B and sporadic medullary thyroid cancer, during thyroidectomy, if you remove the parathyroid, you implant it in the neck itself, in the contralateral sternocleidomastoid muscle. Okay. Why? Because in men 2A, another syndrome will be hyperparathyroidism due to parathyroid adenoma. Okay. So if you reimplant the removed parathyroid in the neck itself, in the future, it may develop parathyroid adenoma. You might need to do neck dissection again, which will be difficult following a total thyroidectomy. So in case of men 2A, where parathyroid adenoma is one of the components, you reimplant the removed parathyroid in the non-dominant forearm brachioradialis. 10 years later, patient will come, sir, I've got a swelling in my forearm. You only operated for my neck, operate for this also. Okay. To your surprise, you might find a parathyroid adenoma there. Okay. So in men 2A, total thyroidectomy, parathyroid removal, implanted in sternocleidomastoid. Men 2B and sporadic medullary thyroid cancer, where there is no chance for parathyroid adenoma, implanted in the opposite neck, contralateral sternomastoid. I hope I am clear. Again, I'm saying let it be an interactive session. If you have any doubts, you can post it in the chat box. Okay. So coming back to the question, the answer for this will be below 5 years. That is men 2A means 5 years, high risk. Okay. In all other codons, other than highest risk and high risk, the thyroidectomy is done after 5 years. What is the false statement regarding Li-Fraumeni syndrome? Li-Fraumeni syndrome is autosomal dominant. It is caused by TP53 gene mutations. TP53 is a tumor suppressor gene. The most common cancer associated with Li-Fraumeni syndrome is breast cancer. The most common sarcoma associated with Li-Fraumeni syndrome is rhabdomyosarcoma. It is the second most common cancer associated with Li-Fraumeni syndrome. Most common sarcoma will be RMS, which will be the second most common cancer associated with Li-Fraumeni syndrome. The other sarcomas are pleomorphic sarcoma, osteosarcoma. The other cancers are adenocortical carcinoma, very important, multiple brain cancers, leukemias, and lymphomas. All these are characteristic of Li-Fraumeni syndrome. The diagnostic criteria used for Li-Fraumeni syndrome will be called as comfort criteria. Okay. So you just have to remember this. You just have to remember the ages. If it is a breast cancer, any breast cancer, if the patient is below 31 years of age, you have to check for 883 is not men 2B. Okay. Only one thing, 918, codon 918 is men 2B. Okay. Other 883 and 674 are, I'm sorry, what is it? Not 674. 634. 634 and 883 are men 2A. Okay. Don't have any doubts. Men 2B is only one. Okay. 918. This thing was asked in the chat box. Okay. So coming back to comfort criteria, if it is breast cancer, it will be age below 31 years of age. If it is any other cancer, it will be 46 years of age. And these three rare cancers, adenocortical carcinoma, choroid plexus carcinoma, and embryonal anaplastic sarcoma. If any patient gets these three cancers, irrespective of his or her family history, you need to test him or her for P53 mutation. If any of these four criteria are present, there should be a high suspicion for Li-Fraumeni syndrome, and genetic counseling and testing should be offered. You must remember the ages alone: breast cancer 31, other cancers 46, or these three rare cancers. Okay. So in females, the penetrance is 50% by the age 31 years. In males, it is 50% by 46 years. Both sexes at the age of 70 years, there will be 100% penetrance. They will be if they live to 70 years, they will be having all the cancers which we have described. Okay. If they live to be 70 years without dying of any cancer, they will be having all the cancers which we have described. Okay. And patients with P53 mutations have increased susceptibility to radiation also. Okay. So radiation-induced DNA damage cannot be repaired by these patients. So they will have increased susceptibility to radiation. So the false statement regarding Li-Fraumeni syndrome will be it is autosomal dominant. Okay. It has P53 mutations. The most common cancer associated is breast cancer, and the criteria used is called comfort criteria. Okay. So false statement regarding carcinoma breast patient who is pregnant. Okay, very, very important topic. I've tried to compile points from Bailey, Sabiston, and Schwartz for this. Okay. Leave alone the options. We will see the facts. Facts about breast cancer in pregnancy. Okay. No need to go for anything else. Just remember these three slides alone. Average age of the patient with pregnant breast cancer is 34. In all pregnancy, 25% of breast nodules diagnosed during pregnancy will be cancerous. In pregnancy, there will be an increased breast density. Therefore, mammogram cannot be used. The breast cancer in pregnancy presents at a later stage due to the masking effects of the hormonal changes. Usually, there will be breast hypertrophy due to estrogen-induced changes in the breast. So, the effects of cancer will be masked. Usually, the breast cancer in pregnancy will be HER2 positive and ERPR negative. Very important. Pregnancy is a hyperestrogenic state, but breast cancer which develops in pregnancy is not expressing ERPR negative, ERPR receptors. It expresses HER2. Okay. Stage by stage, the prognosis for pregnant breast cancer is same as non-pregnant breast cancer. Very important. Coming on to the treatment aspects. The surgery for pregnant breast cancer can be done in any trimester, preferably the second trimester. Okay. Mastectomy is usually preferred. Breast conservation surgery is a relative contraindication, and it can be performed in the third trimester with radiation given immediately after delivery, because once the patient is pregnant, you cannot give the radiation. So if the patient is diagnosed only in the third trimester, you can offer her breast conservation and you can give her the radiation after her delivery. If she is diagnosed in the first trimester, there is no other go. Okay. And then chemotherapy, it is contraindicated in the first trimester. It can be given in second and third trimester. Books mention it is safe to give in second and third trimester. Okay. And one drug, methotrexate, earlier it was used in all chemotherapeutic regimens for CA breast, CMF regimen, etc. CMF, cyclophosphamide, methotrexate, 5-fluorouracil. In the CMF regimen, methotrexate is contraindicated in all trimesters of pregnancy. Okay. Hormone therapy, tamoxifen, letrozole, all these are contraindicated in pregnancy because they interfere with the normal pregnancy physiology. Already pregnancy is a hyperestrogenic state. You also go and give some selective estrogen receptor modulator. It won't work out. Okay. It is contraindicated. Trastuzumab is contraindicated in pregnancy because it causes oligohydramnios. Lactation after delivery is contraindicated when the patient is receiving chemotherapy or hormone therapy or trastuzumab. Okay. After radiation to the breast, after breast conservation surgery, subsequent lactation in the next pregnancy is not possible. Very important. They will be asking an MCQ. All these are false except in the next pregnancy, patient can lactate her baby with her breast. Okay, it is not possible. After radiation to the breast, after breast conservation, usually subsequent lactation in the next pregnancy is not possible. Okay, coming back to the question, which is the false statement? Mammogram cannot be used for diagnosis. Yes, breast density will be high. Mammogram cannot be used. Breast conservation is contraindicated. Yes, it is a relative contraindication. Herceptin can be safely given during pregnancy. No, it cannot be given. It can be given only after delivery. Herceptin causes oligohydramnios. It carries the same prognosis as breast cancer in a non-pregnant woman. Yes, even though it carries multiple adverse risk factors, it carries same prognosis stage by stage as a non-pregnant woman. So the answer will be C. Herceptin can be given safely during pregnancy. Okay. So the next question. Which of the following lymph node is removed or it is not removed? I'm not able to speak. Yes. Which of the following lymph node stations is not removed in D2 gastrectomy? Okay. Important question for a NEET SS level. So this table is taken from Sebastian. Everyone knows the level of lymph node stations for carcinoma stomach. 1 to 6 is perigastric. Then along the named vessels. Yes, mammography with shielding. It can be used if mentioned, but the investigation of choice is MRI. Okay. If they ask mammography with shielding and MRI, both options are there, you have to mention as MRI. Okay. That is the point of that. In SWOTs, it will be given that mammogram can be used if necessary with shielding. That's what they would have been giving. You can better avoid mammography. Okay. No other go, no MRI, you take mammography. But usually you can take mammography. But what is the catch point? Mammography won't be able to pick up the breast cancer in pregnancy because the breast will be having increased density. Okay. So even though you can use mammogram with shielding, it is not going to be much useful for your diagnosis. Okay. That's why the better option would be MRI. Okay. You can use it. It is not contraindicated, but it is of no use for diagnosis. Okay. So this is the table taken from Sebastian. These are all the lymph node stations in CA stomach. So Regarding a D2 gastrectomy for distal gastric cancer, the following nodal stations are removed. Station 1, Station 3, Station 4, Station 5, Station 6. You do not remove the Station 2. Very important. Okay. The next level, yes, thank you, sir. The next level, you remove Station 7, Station 8, Station 9. Station 10, splenic hilar nodes are not at all removed, never removed. Okay. Nowadays, 11P, that is the 11 nodes along the splenic artery. You remove only the proximal 11P, that is proximal splenic artery nodes. Station 12, nodes along the hepatorenal ligament, you remove that also. Okay. So what is D2 plus? The term D2 plus is not mentioned in Savastan and Schwartz, but it gives these things. Okay. So you should know that if station 6 is positive, that is subpyloric station, station 6 is positive or significant, you remove station 14 also, which is the nodes along the superior mesenteric vessels. Sometimes the superior mesenteric vessel nodes are also called as root of mesentery nodes. They may give the option like that also, root of mesentery nodes. Okay. So if station 6 is positive, you remove root of mesentery nodes, station 14. If the gastric cancer is extending to the duodenum also, you remove the station 13 nodes also, retropancreatic nodes also should be removed. If para-aortic node is positive, you can give neoadjuvant chemotherapy, and after neoadjuvant chemotherapy, if the patient is having good response, you can remove the para-aortic node also. Okay. So all these three constitute D2 plus. Okay. That is just something in addition to D2 gastrectomy. Okay. So what is the minimum number of lymph nodes required to be removed in the case of carcinoma stomach? Can someone put it in the chat box? Minimum number of lymph nodes required to be removed in carcinoma stomach. Okay. Someone please put it in the chat box. So coming to the answer, which of the following station is not removed? It is station 10, which is splenic hilar nodes. It is never removed in any gastrectomy, proximal gastrectomy, total gastrectomy, distal gastrectomy, subtotal gastrectomy. They can confuse you in any way. Okay. In any of the cancers also, station 10 is not removed. Okay. Okay. The next question which I saw was this thing. Which of the following is suitable for sentinel lymph node biopsy in pregnancy? They are asking which is suitable. Okay. Technetium 99 sulfur colloid, isosulfan blue dye, methylene blue, and indocyanine green. Okay. Yes, 16. Very good. The minimum number of lymph nodes that is to be removed for gastric cancer is 16. Okay. It is not 15. It is 16. Okay. As per NCCN, it is 16. Okay. So if you are getting both options, 15 and 16, you mention as 16. If you are not getting 16, you are getting only 15, mention as 15. If you are getting only 16, mention as 16. Okay. But if you are getting both 15 and 16, the answer should be 16. Okay. There should not be any doubts at this level for this. Okay. Okay. So there is nothing to explain in this question. So in pregnancy, all the dyes are contraindicated. That is what Schwartz has mentioned. Just a minute. Yes. All the dyes are contraindicated in pregnancy in view of teratogenicity. We might be thinking that this radiocolloid is the one which is contraindicated in pregnancy. It is not like that. Multiple studies have shown that this radiocolloid is very safe in pregnancy with no teratogenic effect on the fetus. So Schwartz mentions very clearly that all these dyes are contraindicated for sentinel lymph node biopsy during pregnancy. And the only thing which can be used is technetium 99 sulfur colloid. I'm sorry, this point should have been put in the previous question regarding breast cancer and pregnancy, but since I saw a separate question, I made a separate question. You can add this point there also. Okay. Technetium 99 sulfur colloid is the one which should be used in pregnancy. All dyes are contraindicated. Okay. So the next big question will be hallmarks of cancer, false statement. I have seen 3 questions from hallmarks of cancer, one regarding proto-oncogenes, and one in hallmarks of cancer, and one another thing in angiogenesis, and one another thing in epithelial mesenchymal transition. Okay. So I've tried to summarize all the hallmarks of cancer in around 10 to 12 slides. I've already taken it in detail in Savastan test number 11 discussion, which I have done previously. If you are in need of the PPT, I will put up my number and mail ID later. You can just mail me. I will send you. Okay. This hallmarks of cancer. What is the false statement? So the first hallmark will be sustained proliferative signaling by the following mechanisms. It is given for 3 pages in the book. I have just summarized all the MCQ points. First is this growth factor receptors are overexpressed. Okay. Which means if you have 2 growth factor receptors, you need 2 growth factors to act. Okay. So the body will be able to control those 2 growth factors. If you have multiple growth factor receptors, if 3 growth factor is coming, it will act. Okay, body will be able to control 2. The remaining 1 will act on the receptor. Okay. 13D. So what is 13D? Station. 13 is retropancreatic lymph nodes. There are no D for that. Oh, option, you are putting option. Okay, right. Okay. So is this the 13th question? Yes. No, false statement will be option B for answer 13 will be explaining it. Okay. So the next will be activating mutations of growth factor receptors. Okay. Which means a growth factor receptor will be mutated and it will be constitutively active. It need not receive any signal for it to function. It will keep on functioning. Okay. This is activating mutation of growth factor receptors. And again, this constitutive activation of growth factor receptors, it is seen in epidermal growth factor receptor in head and neck cancer, KRAS receptor in pancreatic cancer, BRAF receptor in melanoma, thyroid, and colorectal cancers. So these are all the examples given in Sabiston. So anything given as 3, anything which has 3 components is liable to be asked as a MCQ. Okay. Melanoma, thyroid, colorectal have mutant BRAF. Okay. So extracellular matrix receptors like heparin sulfate, integrins, etc., they have switching of subtypes which favor the ones that transmit pro-growth signals. So all these mechanisms are by which cancer cells have sustained proliferative signaling. They keep on dividing. Okay. And then they escape this negative regulation of cell growth by retinoblastoma protein. Okay. Retinoblastoma is another tumor suppressor gene. It is functioning as a negative regulator of cell growth. The points to remember regarding this are the protein product of retinoblastoma gene is called PRB. You know that. PRB acts on the G1S transition phase of cell cycle. You know the phases of cell cycle, G1S, G2M. This G1S interface is where this retinoblastoma protein is active. In the resting phase, retinoblastoma protein is hypophosphorylated. Okay. So this is the diagram. Hypophosphorylated retinoblastoma is active and it controls the gene responsible for progression from G1 to S phase. Transforming growth factor beta is very good. It's a very good molecule. It keeps the retinoblastoma in the hypophosphorylated state, thus preventing the progression of cell cycle. This bypass of this transforming growth factor beta signaling is happening by 2 ways. Downregulation of transforming growth factor beta receptors or expression of mutant receptors. And there is a protein called SMAD4 protein which transmits signals from TGF-beta to downstream targets. Okay. This SMAD4 protein is mutated, which renders the transforming growth factor beta unable to transmit signals. Okay. Transforming growth factor beta needs SMAD4 for transmission of signals. This SMAD4 is mutated, hence signals from transforming growth factor beta doesn't reach the retinoblastoma protein to keep it in hypophosphorylated state. Can anyone say in which genetic disorder related to colorectal cancer this SMAD4 gene is mutated? Can anyone say in the chat box? SMAD4 gene mutation is seen in which colorectal cancer syndrome? Okay. Can someone put it in the chat box? So what happens in HPV infection? The viral oncoprotein E7 binds to retinoblastoma and it inhibits its action. Okay. HPV has E7 and E6 oncoprotein. E7 binds to retinoblastoma. E6 binds to P53. Don't get confused. Multiple exams they have asked this, and always students used to get confused regarding E7 and E6. Remember, 6 is upside down for P, so E6 binds to P53. E7 binds to retinoblastoma. E6 binds to P53. E7 binds to retinoblastoma. Okay. So resisting apoptosis. How does a cancer cell resist apoptosis? Apoptosis is the most common and well-defined form of cell death. It has 2 pathways. You know that, extrinsic pathway and intrinsic pathway. Both the pathways cause the release of cytochrome C from mitochondria of the cell. The extrinsic pathway is dependent upon receptors from outside. The receptors are FAST receptor and death receptor 5. Ligands for this are FAST ligand and TRAIL. Yes, very good, Dr. Shubham Jain. Juvenile polyposis syndrome, very good. The SMAD4 is also called as BRIP1, bone morphogenetic receptor protein 1. Yes. Does any one of you know the expansion for SMAD4? SMAD4 stands for small mothers against decapeptidoplegic hormone, something like that. Okay, just for entertainment purpose, I'm saying. So JPS, what is the differentiating feature between JPS and Peutz-Jeghers syndrome? Anyone? Something related to the layers of the bowel wall. If anyone knows, you can put it in the chat box. Okay. So extrinsic pathways dependent upon these receptors and these ligands. The caspase involved in extrinsic pathway is caspase 8. All these are given in suggestion. That's why I put this intrinsic pathway is it is not depending upon receptors. It is receptor independent. It is caused by cellular stresses and translocation of yes, very good, very good. So where does the change occurs in Peutz-Jeghers syndrome? Translocation of pro-apoptotic molecules from cytoplasm to mitochondria. Okay. So the damage in mitochondria. Yes, very good. Muscularis mucosa in Peutz-Jeghers syndrome. Okay. Very good, very good. Mitochondrial damage leads to cytochrome C release. And the caspase involved in intrinsic pathway is caspase 9 and caspase 3. Okay. There it was caspase 8. Here in intrinsic pathway, it is caspase 9 and 3. BCL2, which is a proton oncogene, has anti-apoptotic activity. So all cancers express BCL2, and that's how they escape from this apoptosis. P53, yes, Peutz-Jeghers syndrome is one of the most important genetic component in carcinoma pancreas. Okay. So what else questions they can ask in this? So in CA stomach also, Peutz-Jeghers syndrome is important. And Peutz-Jeghers syndrome is caused by mutation of STK11 gene. Okay. So these are some of the questions. So which syndrome will be associated with mucocutaneous pigmentation? Anyone? Can they put it in chat box? Just revision for you to stimulate your minds. So it's a long lecture. It was started at 8 p.m. So that's why. Which syndrome is associated with mucocutaneous pigmentation? I'll be going on with the topic. P53 senses DNA damage and activates apoptosis. P53 is called as guardian of the genome. This inactivation of P53 is observed in around 50% of human cancers. And phosphatidylinositol 3 kinase AKT pathway is one of the major pathways promoting anti-apoptosis in cancer cells. Yes, very good, very good. Peutz-Jeghers syndrome, mucocutaneous pigmentation, intussusception due to multiple small bowel polyps is one another classic feature of Peutz-Jeghers syndrome. Okay. No, sir, not in FAP. It is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is the answer. Okay. Other feature is the intussusception. They may ask, I have written one exam where they had asked about intussusception. Okay. Infant or 18-20 years person presenting with intussusception, which syndrome you will suspect? Peutz-Jeghers, JPS, Cronkite Canada syndrome, and FAP. The answer will be PJS. Okay. Peutz-Jeghers. This PI3K AKT pathway will be activated by insulin-like growth factor 1 and 2, interleukin 3, and RAS proton oncogene. It will be inactivated by P10 tumor suppressor gene observed in Cowden syndrome. Okay. And this extrinsic pathway, no, it depends upon receptors. These cancer cells bypass them also by using something called as decoy receptors. Decoy receptor 1, decoy receptor 2. Decoy, means decoy means it is something cheating, cheat code. Okay. Decoy receptor 1, decoy receptor 2, they bind to the receptor. They bind to the ligand, but the function of the ligand is not carried out by the receptor. The ligand will be very good. It will be transmitting signals for apoptosis. It will come and bind with the receptor, and the receptor will not allow the ligand to go inside. Okay. And these two receptors like osteoprotegerin and decoy receptor 3, they destroy the ligands upon binding. Okay. All this is given in Sabistin. And there is one another phenomenon called as autophagy, relatively newer phenomenon, can be asked as an MCQ. In case of nutrient depleted environments, some cells are actively degraded. Such degraded intracellular organelles give rise to metabolites, which allow tumor cells to survive in nutrient limited environments. This is called as autophagy. Human autophagy is important in RAS mutated cancers. Very important. Again, 3 things are coming. Potential MCQ. Pancreas, lung, colon, RAS mutated cancers depend upon autophagy. Human autophagy, it is regulated by a gene called Beclin-1. Okay. It allows autophagy only to be carried out in normal cells. Okay. This Beclin-1 gene is mutated in human cancers, which means the cancer cell can easily eat its surrounding cells to live. Okay. Some cells will be waste, no potential to develop into metastasis. All these cells will be eaten by the main cancer cell. So Becklin-1 is mutated in human cancers. Okay. There are other forms of non-apoptotic cell death like necrosis, ferroptosis. Ferroptosis means it is iron-dependent lipid peroxide accumulation. Okay. Mitotic catastrophe. Mitotic catastrophe means catastrophe in the G2M checkpoint. Very important. G1, they may be asking MCQ like this. Mitotic catastrophe occurs at G1, G2, G1S, G2M. The answer will be G2M. Okay. Then the next hallmark will be replicative immortality. Okay. So how does a cancer cell go into this replicative immortality? The number of doublings each cell can have is controlled by telomeres. Okay. Each telomere will have several thousand repeats of a 6 base pair sequence element. It will be unique for each individual, like this microsatellites. Okay. Microsatellite 6 to 30 telomere will be several thousand repeats of a 6 base pair sequence element. Each DNA replication is associated with the loss of 50 to 100 base pairs. Okay. Once a critical amount is reached, the chromosome cannot divide further. Okay. They undergo end-to-end fusion, leading to karyotype disarray, leading to cell death. Okay. So cancer cells have to escape this phenomenon. If it happens in cancer cells, after 16 to 30 divisions, it will die off and it cannot cause metastasis. See, cancer is the ultimate parasite. I will be saying this in all my classes. Cancer is the ultimate parasite. If you, after your exam, if you have time, you go through these hallmarks of cancer, you will know that cancer is the ultimate parasite. Its only aim is to feed on the human body and cause distant metastasis and kill the patient by multiple mechanisms. We have found out around 30 to 40 mechanisms only. Okay, there are million other mechanisms by which a cancer cell survives. Okay, this cancer cell escapes this telomere loss by producing the enzyme telomerase. Okay, which prevents telomere attrition. Anything with AAC, DNA polymerase, RNA polymerase, telomerase means it is synthesizing. Okay, it synthesizes this telomere. So usually telomerase is present only during embryonic development, but this cancer cells have this telomerase. Okay. Next recent concept will be cancer stem cells. Few points regarding that given in Sabiston. Cancer stem cells are also called cancer initiating cells. Okay. They give rise to a wide variety of phenotypically diverse cancer cells. They can they are present inside the human body and they can generate tumors through self-renewal also. The cell surface markers for cancer stem cells include CD44, CD133, and CXCR4. Again, 3 things are coming, potential MCQ. And within a given tumor, they are extremely rare and they make up only 5 to 10% of the neoplastic cells. Okay, so what happens? Since they make up only 5 to 10%, they are not killed by this chemotherapy and radiotherapy. They are still present within the tumor, and after some time, they cause recurrence and distant metastasis. Okay. And the next hallmark of cancer is angiogenesis. Tumors activate angiogenesis to recruit blood supply. The angiogenesis happens because of disruption of the balance between angiogenesis stimulation and angiogenesis inhibition. Okay. So these are all the angiogenesis inhibitors given in Sabiston: interferon alpha, thrombospondin, tumstatin, canstatin, endostatin, angiostatin. Angiogenesis stimulators like vascular endothelial growth factor, basic and acidic fibroblast growth factor, platelet-derived growth factor, and matrix metalloprotease 9. So both of these things should be in balance with each other. If this balance is disturbed, it leads to either of the one. Cancer cells disturb the angiogenesis inhibitors and promote the angiogenesis stimulators, okay, leading to excessive blood vessel growth. Okay. So these are all the factors favoring. The next hallmark will be invasion and metastasis. So this entire chapter is given in Sabiston. So under the heading surgical oncology, first chapter, hallmarks of cancer. I have summarized this. Okay. So the first factor required for invasion and metastasis is epithelial mesenchymal transition. Epithelial cells are orderly arranged. Mesenchymal cells are disorderly arranged. This is what you should know. And you should know 2 terms, intravasation and extravasation. Intravasation means cancer cells extending from its original site into the bloodstream. That is intravasation. Extravasation, escaping from the bloodstream into some other site, which is extravasation. Okay. Intravasation means entering the bloodstream. Extravasation means escaping from the bloodstream. E-cadherin is a gene which is responsible for forming cell-to-cell junctions. Okay, these junctions are linked inside the cell with alpha, beta, and gamma catenins. Okay, so two cells will be linked to each other by E-cadherin. This E-cadherin will be also linking with the substances inside the cell by alpha, beta, and gamma catenins. Okay, if this E-cadherin is lost, the cytoskeleton of the cell, that is the thing which binds each cell together with itself and also with other cells, is lost. Okay, and this catenin gets accumulated inside the cytoplasm. When these get accumulated, they are called as unsequestered catenins. When E-cadherin is there, it is called as sequestered catenins. If E-cadherin is lost, it is called as unsequestered catenins. Unsequestered catenins, especially beta and gamma catenins, are usually inactivated by APC tumor suppressor gene. The body has a second line of defense. If E-cadherin is gone, it will neutralize this unsequestered catenins by using the tumor suppressor gene APC. Again, when this APC is also mutated only, this catenin can lead to proliferation and tumors. Okay, APC gene mutation is characteristic of colorectal cancer. 85% of colorectal cancers have APC gene mutations. Okay, the other factors are expression of poorly adhesive cellular adhesion molecules, expression of integrins and selectins that favor invasion and metastasis, and docking, this latest concept. Active proteases are present on the surface of cancer cells, which degrade the matrix metalloprotease, the matrix enzymes and the matrix components, and enables the cancer cell to reach the blood vessel. Okay. Just a minute. So one another small question. So what is the minimum number of lymph nodes to be removed in a case of colon cancer? Okay. If anyone knows the answer, you can put it in the chat box. So why do tumors metastasize? There are multiple theories given in the book. Growth factor theory, adhesion theory. Yes, very good. 12 is the minimum number of lymph nodes to be removed in a colon cancer. Very good. You guys have all prepared very well, I hope. I'm happy to see it. Okay. Adhesion theory, chemokine theory, and creation of pre-metastatic niches. All these are factors given for metastasizing of tumors. The next hallmark of cancer is escaping of immune surveillance. Okay. This is done by a phenomenon called as immunoediting. Okay, very important MCQ point, immunoediting. Tumors evolve according to the pressures exerted on them by the immune system. Very important concept. Tumors evolve according to the pressures exerted on them by the immune system, a process called as immune editing. Okay, 99 patients smoke, out of which 9 patients develop lung cancer. It is because of this immune editing only. 1 patient doesn't smoke but gets lung cancer because of this immune editing only. Okay. The first line of defense against tumor cells is the innate immune system. The most important outcome of first line of defense is the production of interferon gamma. Okay. All these are MCQ points, one-liners. Interferon gamma causes tumor lysis, thereby releasing the tumor antigens. Once these antigens are released, they are taken upon by this adaptive immunity. By both these methods, the tumor cells are destroyed. This is called as elimination phase. But only those tumor cells which have high amount of antigens, high immunogenicity, are eliminated by the immune system. Okay. So in the elimination phase, only high immunogenic tumor cells get eliminated. Those tumor cells with low immunogenicity survive. This is called as equilibrium phase. Over time, the surviving tumor cells develop multiple mutations and they withstand the effects of the immune system. Okay. This is called as escape phase. Okay. So what are all the mechanisms? They are given here. You need not know. Okay. So this is immunoediting. The phases are elimination phase, equilibrium phase, and escape phase. 3 phases are there. Potential MCQ. The next is tumor-related. The next is Warburg effect. The heading for Warburg effect is dysregulation of cellular energetics. That is another hallmark of cancer. So what does this Warburg effect means? Warburg effect is the anomalous predilection, which means anomalous means something different, okay? Something apart from the normal. Anomalous predilection of cancer cells to limit their energy metabolism to glycolysis alone, even in the presence of oxygen. This is called as aerobic glycolysis, meaning even in the presence of oxygen, the cancer cells doesn't use oxidative phosphorylation, okay? Even in the presence of oxygen, doesn't use oxidative phosphorylation. It stops its metabolism by glycolysis alone. This is called as aerobic glycolysis. It yields 18 times lower energy than the complete oxidative phosphorylation. Thus, cancer cells needs to upregulate the rate of glycolysis up to 200-fold. Okay, this is called as Warburg effect or aerobic glycolysis. They do this by upregulating the expression of GLUT1, very important MCQ. And this Warburg effect is used to diagnose and stage cancers using the 18-fluorodeoxyglucose molecule PET-CT scan, which utilizes this phenomenon. This 18-fluorodeoxyglucose is getting inside the cancer cell because of this high expression of GLUT1 compared to the normal body. It goes and gets trapped inside the cell because the cell cannot metabolize this fluorodeoxyglucose. Cancer cells can metabolize normal glucose. You inject the body with the 18-fluorodeoxyglucose, cancer cells will think, oh, new glucose is coming, let me take. It will take all the 18-fluorodeoxyglucose inside it, but it is unable to metabolize. The 18-fluorodeoxyglucose gets trapped inside the cancer cell. When we give a nuclear scan, we can see in where all the tissues, the 18-fluorodeoxyglucose is concentrated. And that's how we stage the cancers in using PET-CT, okay? Then the last, I hope this is the last hallmark. 4 different metastatic patterns have been described. First is linear evolution model. The clones of metastasis arise sequentially from the primary tumor, with metastasis occurring from the most recent subclone. Okay, we will have diagrams for this. The next is the early dissemination with parallel evolution model. The tumor clones disseminate early and evolve in parallel with the primary lesion. Late dissemination from a single subclone and late dissemination from multiple subclones. All these are 4 different metastatic patterns which have been described. This is the diagram. Metastasis occurs from a most recent subclone. Metastasis occurs from early to late. Okay, from multiple different subclones from the primary tumor at different stages of the tumor. Metastasis occurs from multiple subclones at the late stage of the tumor. Metastasis occurs from multiple different subclones. Okay, so all these are 4 different models, but mostly the model which is most accepted is this model number 3. Okay, it's because all the distant lesions are similar to each other. Okay, which means only one clone is giving the distant metastasis, and 87% of the age of the cancer should be completed. That means the molecular age of the cancer, in the molecular age, 87% should be completed for a cancer to disseminate. That means it is late dissemination. It is not early dissemination. Hence, overall, the late dissemination from a single subclone is the most accepted model. Okay, the late dissemination from a single subclone is the most accepted model. Okay, can anyone say what is the minimum number of lymph nodes to be removed for a case of carcinoma breast? If you know, you can put in the chat box. Minimum number of lymph nodes to be removed for carcinoma breast. Okay. So this one question, of the 4 distant metastatic patterns, which is the most accepted pattern? The most accepted pattern is, yes, sir, all cancers to start with are monoclonal. Okay, all cancers to start with are monoclonal. They develop multiple mutations and become polyclonal. Okay, all cancer cells arise from single cell. They are monoclonal. During the course of its survival to establish distant metastasis, it needs to get differentiated into multiple subclones. That's how it survives. If the cancer cell is having a same cell with same antigenic expression, it will be destroyed by the immune system. Okay, we have just now seen the evolution of the cancer cell is dependent upon the pressures exerted on it by the immune system. Okay, later they develop into polyclonal things. Okay, see, you see breast cancer. Okay, it will be ER/PR negative, HER2 positive, primary breast cancer. Okay, you will be treating it with MRM. After 2 years, the patient will come back with spine metastasis. if you take that metastasis biopsy and immunohistochemistry, the patient will be ER/PR positive and HER2 negative. How to explain this phenomenon? Okay, I've seen multiple cases like this. Okay, initially HER2 positive, ER/PR negative. After some time, recurrence or metastasis, the entire IHC picture will be changed. So initially, cancer develops from a single subclone. It is monoclonal. Later, it becomes polyclonal. Okay. So the answer for this will be, of the following 4 distant metastatic patterns, the pattern of late dissemination from a single subclone is the most accepted pattern. And yes, the number of lymph nodes removed for breast cancer is 10. Okay, very nice, very good. And let me put forth another question. What was the ATLAS trial, ATLAS trial regarding tamoxifen? Okay, ATLAS trial regarding tamoxifen duration. What is the ideal duration of tamoxifen to be given based on the ATLAS trial? Okay, we have seen all the trials for HER2/neu. So just one question regarding trial for tamoxifen, ATLAS trial. If anyone knows what is the ideal duration for tamoxifen treatment, just put it in the chat box. Okay, how many years? So we have come to the end of hallmarks of cancer. So coming back to the question, the false statement regarding hallmarks of cancer is anaerobic glycolysis. It is not anaerobic glycolysis. It is aerobic glycolysis. Okay. Aerobic glycolysis, nothing but Warburg's effect. Okay. 10 years. Yes. Very good. The trial ATLAS stands for adjuvant tamoxifen long against short. Okay. It compared 5 years with 10 years and concluded that 10 years is the ideal duration of treatment for tamoxifen. Very nice, very good. Okay. Yes. The false statement regarding hallmarks of cancer will be anaerobic glycolysis. Okay. So one another question which I was saying was oral squamous cell carcinoma with infiltration of mandible treatment plan. Okay. So in order to clear all confusions, I have put here 3 statements. Okay. Any of these 3 statements can be asked in the exam. Abutment of mandible by a oral cavity tumor, but not adherent to the mandible or periosteum. What will be the plan? The plan will be periosteal stripping alone. Okay. Just abutment, you strip the periosteum. If the tumor is adherent to the periosteum or periosteum is involved by the tumor, but on CT scan or X-ray, there is no irregularity on the surface of the mandible, which means the mandible is free, only the periosteum is involved, you do marginal mandibulectomy. Okay, you do marginal mandibulectomy. And if the mandible is invaded by the tumor, you do a hemimandibulectomy or segmental mandibulectomy. If the mandible is invaded by the tumor, you do a hemimandibulectomy or segmental mandibulectomy. Okay, so this is the concept for oral squamous cell carcinoma with regard to the mandible. Only abutment, periosteal stripping, adherent to the periosteum, marginal mandibulectomy. If mandible is invaded, hemimandibulectomy or segmental mandibulectomy. You always have to stay one step ahead of the cancer. Okay. Next, mutation in familial gastric cancer. All true except E. cadherin, APC, STK11, P10. Okay. So these are all the hereditary gastric cancer syndromes. Hereditary diffuse gastric cancer, Lynch syndrome, juvenile polyposis, Peutz-Jeghers, familial adenomatous polyposis, and Li-Fraumeni syndrome. So one syndrome deserves special merit. Hereditary diffuse gastric cancer syndrome. It is famous because it was present in the family of Napoleon Bonaparte. Okay, it is an autosomal dominant syndrome. It is caused by germline inactivating mutation in tumor suppressor gene CDH1, that is E. cadherin. Difference between abutment and adherence, sir. Yes, abutment means the tumor will be mobile. Okay, the tumor will be mobile, even though on clinical examination, if the tumor is appearing to be very close to the mandible, if you examine very carefully, you will be able to move the tumor. It will be just nearby the mandible, but you will be able to move the tumor. In such cases, it is called abutment. In such cases, periosteal stripping is enough. If on clinical examination, if you are unable to move the tumor is located very close to the mandible, it means the tumor has invaded the periosteum of the mandibles. You all know, I'm very sure, any tumor arising from the bone is immovable, right? You all know that. So this tumor is attached to the periosteum. Yes, is invaded the periosteum, which means it is not mobile. So any tumor which is not mobile has invaded the periosteum. So next step, you will be taking a CT scan or X-ray or orthopantogram. there you'll be seeing that the mandible surface is intact. Okay, it has not breached the cortex and gone inside, which means the tumor is just invading the periosteum alone, since it is not mobile. In such cases, you have to do marginal mandibulectomy. You have to remove a rim of the mandible to give adequate margins. You have to stay one step ahead of the tumor. Then, if it is not mobile, in CT scan also, there are multiple bony irregularities in the mandible, which means that it has invaded the mandible. You have to stay one step ahead of the tumor, so you remove the mandible. You either remove it fully, it is called as hemimandibulectomy. You remove it partially, it is called as segmental mandibulectomy. Okay, I hope it is clear. Okay, the next question in the chat box is, in carcinoma breast, after breast conservation surgery and sentinel lymph node biopsy, what are the indications for axillary dissection? Okay, just 2 to 3 sentences I will say regarding sentinel lymph node biopsy. Sentinel lymph node biopsy is carried out in N0 neck. Okay, N0 axilla. Very important. In case of N1, that is clinically palpable nodes in axilla, you do axillary dissection. Okay. Then, in case of N0, you do sentinel lymph node biopsy. If the sentinel lymph node biopsy comes out as positive, you do axillary lymph node dissection. Okay. This was given by a trial called as NSABP B32 landmark trial. Okay. They say that in N0 axilla, if the sentinel lymph node is positive, then only it is enough to do axillary lymph node dissection. If it is not positive, you do sentinel lymph node biopsy and you can keep the axilla under observation. Then came a latest trial, ACOSOG, ACOSOG Z0011. Okay, it is given in both Sabiston and Schwartz. ACOSOG Z0011 trial, which stated that even if you are doing sentinel lymph node biopsy, you can have up to 2 to 3 sentinel lymph nodes positive in the sentinel lymph node biopsy. Then also you can avoid axillary lymph node dissection. That's what they told. Okay. Usually the traditional teaching is, if sentinel lymph node is positive, you do completion ALND, axillary lymph node dissection. But if up to 2 nodes, I mean, it is not 3, it is 2 nodes. If up to 2 nodes are positive in the sentinel lymph node biopsy, you can still avoid axillary lymph node dissection. There are no difference in the survival outcomes. Okay. So if you are getting a question like sentinel lymph node biopsy done, no lymph node positive, what is the next step? You have to write as axillary observation. Okay. Axillary observation. If they are asking sentinel lymph node biopsy shows 1 node positive and they are giving options like observation and axillary dissection, you write as axillary dissection because they are given as 1 node. For any difficult question, you have to just think of the examiner. What is he trying to ask in this question? That's what you must think. Okay. If he has given us 1 node, you write as axillary dissection. If the question specifically mentions there are 2 sentinel lymph nodes positive, okay, that means the examiner is trying to test whether you have learned about this ACOSOG Z11 trial. Okay. In that case, if you are getting the option as observation and axillary dissection, you can go for observation safely. Okay. Because the question is that 2 sentinel lymph nodes are positive. Okay. You can go for observation based on the trial ACOSOG Z11. Okay. If the examiner is asking only 1 lymph node is positive, the examiner is just testing whether you know the concept of sentinel lymph node. Okay. In that case, you can safely put ALND. If the question mentions specifically 2 lymph nodes in sentinel lymph node positive, it is regarding the testing of ACOSOG Z11. So in that case, you put as observation. Okay. So both these trials are given in both Sabiston and Schwartz. And what is encasement means? In mandible, there is usually no term such as encasement. Encasement is traditionally mentioned in carcinoma of pancreas. Abutment is less than 180 degree of contact of tumor with blood vessel. Encasement means more than 180 degree contact of tumor with blood vessel. Okay. No controversies. Abutment less than 180. Encasement more than 180. Okay. And one another question in the chat box, we will solve that also. Is there any role for sentinel lymph node biopsy in head and neck cancers? Yes, there is an upcoming role. No need to worry about it for NEET super specialty level. No need to worry. They won't be asking. It is not followed in all cancer centers. Only 2 to 3 trials have validated it. Okay. They have also raised multiple questions. So sentinel lymph node biopsy is just upcoming in head and neck cancers. They won't ask regarding that in exam. Don't worry. Even if you have any doubt regarding that, no need to read it for exam. Okay, it won't come. Okay, don't worry. If there are no other doubts, we can go with the topic. Just one or two questions more. And even if you have any doubts regarding any other cancers, you can put in the chat box. Okay. So hereditary diffuse gastric cancer is also called Bonaparte syndrome, autosomal dominant syndrome, germline inactivating mutation in tumor suppressor gene, CDH1. Yes, thank you. It is present in the chromosome number 16q. Okay. Can anyone put the chromosome numbers for BRCA1 and BRCA2? Very important, Schwartz. BRCA1, BRCA2 chromosome numbers alone. Okay, what are the chromosome numbers? Put it in chat box. I'll be happy if you do so. This E-cadherin plays a major role in epithelial mesenchymal transition. We have just now seen in hallmarks of cancer. E-cadherin is the one which attaches to both cells, and also inside the cell, it attaches to alpha, beta, and gamma catenin. Okay. So it needs 2 hits. It was first described in New Zealand Maori families. It has a risk of developing diffuse gastric cancers at young age. The average age of diagnosis is 37. The lifetime risk is 67 for males and 83% of females. Very good. It is 17 and 13. Very nice. Very nice. Anyone knows for men 1 and 2? What is the chromosome number for men 1 and men 2? If anyone knows, you can put it in chat box. The females with E-cadherin mutations are at a higher risk for developing lobular breast cancer. Very important. Females with E-cadherin mutations are at a higher risk for developing lobular breast cancer. Yes. 40% of patients with hereditary diffuse gastric cancer do not carry CDH1 mutations. Men 1 11, men 2 10. Very good. Men 1 11, men 2 10. Okay. Yes. Very nice. Very nice. The patients which do not have CDH1 mutations carry PALB-B2 gene mutations. Okay. The expansion for PALB-B2 is partner and localization of BRCA2, which is necessary for the function of BRCA2 gene. Hence, gastric cancer can also occur in some BRCA families also. Okay. Other genes in hereditary diffuse gastric cancer are STK11, PRSS1, CTNNA1. Okay. CTNNB1 is beta catenin, colorectal cancer. CTNNA1 is alpha catenin, stomach cancer. The earliest lesion in hereditary diffuse gastric cancer is intramucosal signet ring cells. Okay. Intramucosal signet ring cells. So these are the testing criteria for hereditary diffuse gastric cancer. No need for your exam. Just you need to know that something like this exists. So this is given in Saveston. What to do after a hereditary diffuse gastric cancer is detected? Okay. Prophylactic total gastrectomy is recommended between 18 to 40 years. The prophylactic gastrectomy is not recommended less than 18 years. Okay. And screening with multiple biopsies every 6 months to 12 years is recommended for patients who do not want to undergo prophylactic gastrectomy. Say, I have E-cadherin mutation, sir, I don't want surgery and all, I'm very scared. What can I do? You can undergo repeated biopsy, but with the condition that if one of the biopsies is malignant, you have to undergo surgery. Okay. Endoscopy might not adequately detect the precursor lesion in hereditary diffuse gastric cancer. And there are no other options other than surgery and surveillance are available. Okay. So prophylactic total gastrectomy is done in hereditary diffuse gastric cancer. Before doing, you must confirm that there is no other cancer inside by endoscopy. And after you have cut the stomach and removed, you must do a frozen section. So yeah, to do frozen section to analyze whether the proximal and distal margins doesn't contain any gastric mucosa. If the distal margin has gastric mucosa, that margin you have left behind is liable to develop cancer. Okay. So you have to again go on dissect. Okay. So traditional surgery for gastric cancer is D2 lymph node dissection, which is not required in case of total gastrectomy because the cancer has not yet developed. Okay. The next will be Lynch syndrome. You all know about it. We already discussed. CA stomach and Lynch syndrome is the second most common extracolonic malignancy. Okay. You have to remember that. JPS, you know, juvenile polyposis. You have just now asked in the chat box, SMAD4 or BMPR1 alpha. BMPR is bone morphogenetic protein receptor 1 alpha gene. Okay. It has multiple juvenile polyps and has a risk for developing gastric cancer also. PJS, very nice. You all know autosomal dominant STK11 tumor suppressor gene, mucocutaneous pigmentation with GI polyposis, 29% risk of developing gastric cancer. FAP, everyone knows germline mutation in APC gene. Usually in FAP, the polyps found in the stomach are usually benign. Very important point. The polyps found in the stomach are benign, fundic gland polyps. Okay, of which 90% are benign and only 10% may lead to gastric cancer. Okay. Okay, coming back to our question. Mutation in familial gastric cancers are all except E. Catherine, yes, occurs in the family of Napoleon Bonaparte. E. Catherine causes hereditary diffuse gastric cancer. APC gene causes FAP. STK11 causes Peutz-Jeghers syndrome, all is included in hereditary gastric cancer. P10 gene. Can anyone say what does P10 gene mutation causes in the chat box? P10 gene mutation. What does it? What disease does it cause? I'll be waiting for your answer. Rest of the questions will be discussed. All your doubts we will discuss. Yes, Cowden syndrome. P10 syndrome, P10 gene mutation causes Cowden syndrome, where there will be colorectal cancers, breast cancer, and thyroid cancer, but stomach cancer is not a part of Cowden syndrome. Okay. So the answer here will be P10 gene mutations. Okay. So there are two doubts in the chat box. In medullary thyroid cancer, indication for bilateral neck dissection. Okay. So you have to understand that in medullary thyroid cancer, you always have to stay one step ahead of the tumor. Okay. You always have to stay one step ahead of the tumor. The tumor marker for medullary thyroid cancer is serum calcitonin. Okay. Serum calcitonin. Okay. So you divide the calcitonin values like this. 20, you remember like this. 20, 50, 200, 500. Okay. 20, 50, 200, 500. Okay. So if a medullary thyroid cancer is limited to the thyroid, which is intrathyroidal, okay, you have to stay one step ahead of the cancer. So you do, in which lobe the cancer is there, you do total thyroidectomy, and that side lobe alone, that side alone, you do ipsilateral central compartment lymph node dissection. Okay. You all know that central compartment is a single compartment, but it is mentioned in oncology textbooks like that. Okay. Which lobe the cancer was there, that side you do central compartment lymph node dissection, which is the minimumest procedure you should do for medullary thyroid cancer. You always have to stay one step ahead. Okay. Based on the serum calcitonin values, then the next steps occur. Okay. If the value is more than 20 picogram per ml, okay, what is the unit for calcitonin is picogram. Okay. If it is more than 20 picogram, you have to do ipsilateral lateral neck node dissection also. Okay. You have to do ipsilateral lateral neck node dissection also. Okay. If the value is more than 50, you have to do total thyroidectomy, ipsilateral central node, ipsilateral lateral node, and contralateral central node if the value is more than 50. Okay. The next cutoff is 200. If the calcitonin is more than 200, you do total thyroidectomy, ipsilateral central node, ipsilateral lateral node, contralateral central node, and contralateral lateral node. The cutoff for doing a contralateral lateral node or bilateral neck dissection, as asked in this question, is 200 picogram per ml. If the value is 500, there is no point in doing surgery, because 99.99 patients with calcitonin of 500 will be having distant metastasis. The textbook will be giving us, go and search for distant metastasis. You are operating on a futile patient. That's what the textbooks will be giving. Okay. So divided into 20, 50, 200, 500, 20 ipsilateral. I mean, normal surgery is total thyroidectomy with ipsilateral central, 20 ipsilateral lateral, 50 contralateral central, 200 contralateral lateral, 500 distant metastasis. Okay. And this is based on serum calcitonin. If structurally, if the patient is already having central node, you have to do ipsilateral lateral node. If the patient is already having ipsilateral lateral node clinically, you have to do contralateral lateral node. Okay. That is staying one step ahead of the tumor. Okay. If already central compartment node is there, if already no central compartment node is there, you have to do total thyroidectomy with central compartment. If central compartment node is there, you have to do total thyroidectomy central node, ipsilateral node. If already ipsilateral lateral node is there, you have to do contralateral lateral node. This is one another concept in medullary thyroid cancer. So hope that doubt is clear. Okay. When do we do bilateral neck dissection? Okay. So why do we give suppressive L-thyroxine after total thyroidectomy? So suppressive L-thyroxine is given for two reasons. Okay. The first is you are removing the thyroid, and the patient won't be having L-thyroxine, so you must give L-thyroxine supplementation. Okay, that is the first reason. The second reason is follow-up of differentiated thyroid cancer is done nowadays with radioactive iodine scans. Okay, follow-up of differentiated thyroid cancers is done nowadays with radioactive iodine scans. Okay, radioactive iodine scans depend upon the uptake of iodine by any metastatic foci. Okay, so that's why we do total thyroidectomy. If you are doing a near hemithyroidectomy for a cancer, and if the patient has a spine mets later, if you give a radioactive iodine, all the iodine will be taken up by the residual opposite lobe. None of the radioiodine will be going to the spine mets, so you cannot diagnose. Okay, so that is the reason we do total thyroidectomy. Okay, so why do we give suppressive L-thyroxine is all differentiated thyroid cancers are TSH dependent. Okay, all differentiated thyroid cancers are TSH dependent. Okay, so you should not let the TSH rise in the body. Okay, you all know there is a risk stratification for thyroid cancers: low risk, intermediate risk, high risk. For low risk, the target TSH value will be 0.5 to 2 milli-international units per ml. For intermediate risk, the target value will be 0.1 to 0.5. For low risk, it will be less than 0.1. For high risk, it will be less than 0.1. Okay, 0.1, 0.1 to 0.5, 0.5 to 0.2. High 0.5 to 2, high, intermediate, low. 0.1, 0.1 to 0.5, 0.5 to 2, high, intermediate, low. Okay, this should be the target TSH value, because all differentiated thyroid cancers are TSH dependent. So earlier in your UG days, you would have learned that the suppressive dose is 300 micrograms. Okay, the current concept is any dose which is able to keep the TSH in this level is called as suppressive dose. Okay, any dose which is able to keep the TSH in this level is called suppressive dose. Okay, so is that question clear? And regarding follicular thyroid cancer, okay, so the same thing, the same principles for papillary thyroid cancer and follicular thyroid cancer. Okay, if you are sure that the tumor is intrathyroidal, okay, the biggest prognostic factor apart from regional nodes in thyroid cancer is extracapsular extension. Okay, so if you are sure that the tumor is intrathyroidal, it has not come out of the thyroid gland, the capsule is intact, none of the lymph nodes are palpable, it is enough to do a total thyroidectomy. Okay, if you are unsure during intraoperative procedure, if there are adhesions or the tumor is very big, you might suspect that it is come out of the capsule microscopically, you have to do lymph node dissection. If there are no lymph nodes palpable, it is enough to do central compartment dissection. Okay, no need to touch lateral lymph nodes if the lymph nodes are not palpable in a CA thyroid, that is papillary thyroid and follicular thyroid. Okay, I hope I am clear. It is very different from medullary thyroid cancer. Okay, medullary thyroid is not a differentiated thyroid cancer, it is a separate topic. Differentiated thyroid cancer includes only three: papillary thyroid, follicular thyroid, and Hürthle cell thyroid. In all these three, there is no use in doing lateral lymph node dissection either on the ipsilateral side or on the contralateral side in the absence of palpable nodes. Okay, only if the nodes are involved, you do. Okay, even if central compartment nodes are picked up in ultrasound or intraoperatively, you can do only central compartment alone. No need to do lateral compartment in the absence of enlarged nodes. It is different from medullary thyroid cancer. I hope I am clear. I hope I am clear. If you have any doubts or if you want me to repeat, you can put it in the group. Which point you are not clear, you can put it in the group. Okay. I'll wait for 2 minutes for further doubts. Is it okay regarding thyroid? There is no need to do central compartment dissection if you are sure that the thyroid is intrathyroidal. Most of the surgeons do not take that risk. They do total thyroidectomy with central compartment lymph node dissection. Even if central compartment lymph nodes are positive, there is no need to do lateral neck node dissection if the lymph nodes are negative in a case of differentiated thyroid cancer. Only if the lymph nodes are involved, you do lateral neck dissection. Okay. This concept is for differentiated thyroid cancers. For medullary thyroid cancer, you stay one step ahead of the tumor. There are two concepts. You stay one step ahead, and the other concept is regarding the based on the calcitonin values. Okay. If you want me to repeat anything, just put it in the group. What do you want me to repeat? And I think that's all the discussions for today. Sir, for differentiated thyroid cancer, yes. Yes, that's what I'm saying now. No, I will say now. In the case of differentiated thyroid cancer, there is no need to do central compartment lymph node dissection if you are sure that the tumor is intrathyroidal. Okay. If you are operating on a 1.5 cross 1 centimeter tumor, very small, okay, you will be very sure that there is no extrathyroidal extension. In that cases, no need to do. If you are unsure or if you have a doubt that there will be microscopic extracapsular extension because there are adhesions in the neck, or if the tumor is very large, or if you have a suspicious central compartment node palpable intraoperatively, you have to add central compartment lymph node dissection with total thyroidectomy. Okay. There is no need to do lateral compartment dissection in the absence of lateral compartment nodes. Okay. So most of the surgeons, since they are unsure that the central compartment, they are unsure whether there is extracapsular extension, they add this central compartment dissection as part of their procedure. Since it is very easy, no need of any separate incision, they add it. Okay. So in exam, if you get a question, 2 cross 2 centimeter tumor, no extrathyroidal extension intraoperatively. If they mention that point, you have to think of the examiner. What is he expecting? He expects you to know that in a case of thyroid cancer with no extrathyroidal extension, there is no need to do central compartment lymph node dissection. Okay. So in the exam, if you get a question like 2 cross 2 thyroid cancer with no extrathyroidal extension, what is the appropriate procedure? Total thyroidectomy, total thyroidectomy, total thyroidectomy. Okay. In the exam, if you have a question, 3.5 cross 2 centimeter tumor, nothing else is given. Okay. Then the answer will be total thyroidectomy with central compartment lymph node dissection. That's all. The concept here is if the tumor is intrathyroidal, no need to do central compartment. If you have suspicion that the tumor is extrathyroidal, or intraoperatively if the tumor is extrathyroidal, or intraoperatively if the central compartment nodes are enlarged, you have to do central compartment lymph node dissection. No need to do lateral lymph node dissection in case of differentiated thyroid cancers in N0 neck, in absent lateral lymph node enlargement. Okay. Medullary thyroid cancer, you have to stay one step ahead. Okay. I think that I've cleared your doubts. If you have any more doubts, you can put in the chat box regarding any other cancers also. Okay. Now, don't put this brain malignancies and all. I don't know about that. And pediatric malignancies also. Just put for adult cancers. I'll be able to answer. So this is my phone number and my mail ID. If you want this PPT, which we have used for discussion today, you can just send me in WhatsApp or you can send me a mail. I will just share it with you. Okay. You can use it for studying rapid revision. So a few tips regarding studying. Study all the tables. Okay. All the tables given in Saveston and Bailey. All the tables. Okay. You have to take screenshot and keep in your phone or in your tab. Most of the examiners are lazy. They won't go through the text at all. See how the questions will be prepared. They will be getting around 30 to 40 surgeons from all over India, mostly from North India, they will be getting, and they'll be asking to pick up the questions. Most of them are old persons. They won't be able to read the questions. Okay. They will be just looking at the tables and prepare questions based on that. Okay. So try to read all the tables in Bailey and Saveston. Okay. In that way, you can attend 50% of the questions. I'm very sure 50% of questions you'll be able to attend. Okay. Write and keep separately names, numbers, genes, triads, triangles, all these things. Write and keep separately. At least 5 questions you'll be getting in all these things. numbers, names, genes, syndromes, triangles. Okay. In all these things, you will be getting at least 5 questions. Okay. And urology, the previous session, which was carried out by Dr. Dattatreya, is very important. Okay. Urology, especially from Bailey and Schwartz, is very important. Sebastian urology is not given so much. All those congenital things will be asked repeatedly. They have been asking for the past few years. Okay. The highest number of questions is from urology and oncosurgery only. Okay. But oncosurgery also, you can divide it according to systems. GI cancers can be considered under GI system also. But urology, highest number of questions every year. Okay. It's very important. Then one more thing which you should not forget is plastic surgery. They ask around 5 questions every year, plastic surgery. Flaps, various reconstruction techniques, some idiotic things they will be asking 5 years. Okay. Last year I took classes for plastic surgery and hand surgery also. If you want those PDFs also, you can just message me and ask. Okay. I will share those PDFs also. I have taken for NEET SS 2022, I think. Yes. NEET SS 2022 and 2023, I have taken plastic and hand surgery and burns also. All these topics I have taken. I'll just send you those PDFs also if you want. Okay. If you're not prepared till now, you get those PDFs from me and you can prepare very easily. If you have prepared, no need. Okay. Then if there are no more doubts, we can close the session. And thank you all for your cooperation. Hope this session was very useful to you. Okay. Yes. Thank you. Sir, we can stop the session.